Hello, I'm Dr. Betty Farrell, and as chair of this study and of this committee, I'd like to welcome everyone. The task being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to examine how our nation delivers, finances, regulates, and measures the quality of nursing home care. The committee's full official statement of task can be found on the project website. I would also like to acknowledge our sponsors for this project. The committee members are listed on the screen, but we will not have time for each committee member to introduce themselves in order to save time. I would like to remind everyone that this is an information gathering session. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. We are also inviting residents, family members, and nursing home staff to submit their stories and experiences in the link provided. Today's webinar will be recorded and archived at the link shown on the screen. I want to note that this is an open, on-the-record session. Individuals from the public have been invited to attend as observers, and we will not be entertaining questions from the floor. Please do note, however, that anyone can submit testimony or other materials to the committee at any time, and these documents will be placed into the committee's public access file. You can submit this information through the project's website. The first session of today's webinar will explore industry perspectives. We have given each speaker only 10 minutes for their remarks, and I kindly ask the speakers to be respectful of this time limit so that we do have time for ample discussion with the committee members. I would like to introduce the moderator for this session, Dr. Philip Sloan.
Thank you, and good morning, committee members and guest presenters. This morning's session focuses on perspectives from representatives of organizations that are on the front lines of care in nursing homes. I will briefly introduce all four speakers now to allow maximum time for presentation and discussion. Full speaker bios are available in the last 4 pages of the webinar briefing book. Our first two speakers represent the two major nursing home provider organizations. Mary Ousley, our first speaker, is co-chair of the Quality Cabinet of the American Healthcare Association. Ruth Katz, our second speaker, is Senior Vice President of Public Policy and Advocacy for Leading Age. Our third speaker, Robert Kramer, is co-founder and strategic advisor for the National Investment Center for Seniors, Housing, and Care, which gathers and disseminates data and analytics and makes policy recommendations regarding all areas of senior housing, including nursing homes. Lastly, we will hear from Michael Wasserman, a geriatrician and innovator in health services provision for older persons. He is currently chair of the Public Policy Committee of one of the largest medical provider groups, the California Association of Long-Term Care Medicine. To our speakers, thank you again for joining us. We know that 10 minutes is very short, but please, for the sake of others, do your best to stick to the allotted time. I will turn my camera on after 9 minutes to alert you to begin wrapping up. After all 4 presentations, we have allotted up to 40 minutes for discussion between the committee and our presenters. And now, Mary Ousley, the floor is yours.
Thank you, Dr. Sloan. Good morning, and thank you for members of the Academy and fellow panelists. I am pleased today to speak on behalf of the American Healthcare Association National Center for Assisted Living. Our association represents over 14,000 for-profit and not-for-profit nursing centers, as well as assisted living. To say that 2020 was a difficult year is, I think, to put a bit of an understatement. As I prepared for today, 4 words came to mind: sadness, fear, stress, and pride. Sadness and fear for the unbelievable loss of life and devastating impact on our nation and the world. Fear for our residents, our families, and some days for ourselves. Stress such as I have never experienced before in my career, especially in the early days when so little was known about this virus. And pride, incredible pride, on behalf of the millions and millions of caregivers who have gotten up every day and touched the lives and provided the care in our nation's nursing centers. An unprecedented public health crisis, nowhere more so than in our long-term care population, most over the age of 85, with multiple chronic conditions. 1 million cases reported and over 145,000 deaths since the start of the pandemic. Early on, we realized that what predicted an outbreak was not quality ratings or even past infection control citations. It was positivity in our surrounding communities. The most rigorous infection control practice, while critical to have in place, could not stop this highly contagious virus. Post-acute and long-term care were not the top priorities, and that again made those early months really difficult. But by early spring, we were getting close to an adequate supply, or early summer, an adequate supply of personal protective equipment, and in the early fall, testing supplies and equipment. We began the slow turn. Now, not to say that we did not have the same surge as we've seen in our individual states and communities. Prioritization of our patients and our employees for receiving the vaccine requires words really beyond appreciation. And I know I have, and I think everyone has, thank God, every day for this blessing. We are seeing the impact. For the first time this week at Pruitt Health's daily call on Tuesday, we had no new cases. On Wednesday, only 2. And I wasn't able to attend the meeting this morning. The financial impact on our profession has been astronomical. Supplies, staffing, and again, we are forever thankful for the CARES Act and the support that we have received. But I do want to emphasize that we are nowhere close to out of the woods on the economic front. Our association is committed to learning, creating a stronger long-term care system for the future based on this experience. We recommend several approaches, focusing on 2 themes: building the workforce and the regulatory framework to create and achieve quality care. Throughout my career, an overarching goal has been for others to see the profession as I see it, and have all of those who dedicate their careers to this profession receive the respect they so richly deserve. We have come a long way in the last 20 years, but we have a long way to go and miles to go before we sleep. As a result of the pandemic, staffing shortages have been exacerbated. Illness, exposure, quarantine, childcare, and just the need for more staff to provide more individual care to stop the spread. We need a system that leverages federal, state, and academic resources with incentives and support to attract and retain quality staff. Our recommendations: loan forgiveness and tax credits for professionals who work in this sector, programs for affordable housing and child care assistance, increased subsidies for professional schools whose graduates work in nursing homes for 5 years. An immediate need: a pathway for our temporary nurse aides to become full certified nursing assistants. Many states now are creating these pathways, but a federal one would be nice. And don't forget, respect. Our association continues to review the recommendations on the Commission on Safety and Quality from the Commission on Safety and Quality, especially related to the use of the registered nurse and infection preventionist, and we commit to continue to work on these proposals. The need for long-term care and post-acute care is not going away. So it is really now is the time for us to think out of the box as to how do we make this a stronger profession and prevent issues such as what has occurred in the future. From the perspective of using regulations to achieve quality of care in nursing home, I just want to say that the survey system has not fully evolved to be able to reflect the science of quality improvement and how to use oversight to create change and achieve desired outcomes. The punitive nature of the process drives quality staff out of long-term care to other settings where the oversight process focuses on culture of safety and continuous improvement. Today, adverse events are frequently enforced under strict liability standards, with facilities being cited for abuse and neglect just because it happened, not that the center did anything wrong or failed to meet all standards to prevent such an occurrence. As a result, professionals are fearful to work in long-term care because their license, their livelihood is being put on the line. This is not to downplay the seriousness of even one case of abuse. It is not to be tolerated. A better approach is needed to foster a shared responsibility for improving across all providers. And we offer the following recommendations. Incentivize providers to improve through quality initiatives rather than punishing with citations and fines. Base the system on the principles of quality assurance, improvement, and performance improvement, distinguishing between those centers that have a robust QAPI program and corrects issues before they arise to the level of noncompliance or harm to resident, and those centers who do not have such a program. Develop mechanisms to determine how to use scarce resources for survey and certification. Perhaps survey consistent high performers less frequently. Support continued collaboration with the Quality Innovation Network and Quality Improvement Organization to support nursing health centers who need help in achieving and maintaining a QAPI approach to sustain compliance. Apply enforcement remedies from the perspective they were intended. Remediation to achieve and sustain compliance. Remediation, they are remedies. Some need more and some need less or none. I have been honored to represent the American Healthcare Association over the last 30 years, and never more so than since 2012 when we started our quality initiative. During this period of time, we have seen real improvement in patients not returning to hospitals, decrease in the number of antipsychotics, and improvement in 18 of the 24 quality indicators. On behalf of the association, I want to say we are committed to implementing the recommendations of the commission as well as the recommendations for the Academy. Thank you very much for this opportunity.
Thank you. We'll move on now and hear from Ruth Katz. Appreciate those comments. Ms. Katz.
Okay. My video on. All right. Okay, Mary, that was beautifully put, and I'll have to tell you guys up front, you're going to hear a lot of consistent themes here. I'm really honored to be here with you and really grateful to you for this gigantic task that you have undertaken. So I lead the policy shop at Leading Age. We represent more than 5,000 not-for-profit and other committed, value-driven providers of aging services. About 2,000 of our members are nursing homes. About 2,000 of our members are low-income senior housing, home and community-based services members, CCRCs or life plan communities, hospice, home health, adult day, across the whole spectrum of aging services. I want to start off by saying there will always be a need for a place, a residential place, where people who need a lot of help with basic activities just to get through the day can live and receive services. People with advanced dementia are disproportionately represented in that group. Most people in nursing homes today do not have, the reason that they're there is because they do not have an extensive informal caregiving system that can provide care all day and all night. It's a small number of people compared to all the people over 65 in the country, all the people that need help in the country. But it's a population that, as the older population balloons, is also probably going to increase. Most of you guys have been toiling around in this vineyard for a long time. And what's changed? Something's changed, right? Instead of 10 of us in a room talking to each other and kind of knowing what we can expect each other to say, all of a sudden, COVID's changed everything. So we're looking now, for example, at a nearly $2 trillion relief. I mean, in this moment, we are looking at a nearly $2 trillion relief package in the House that includes proactively nursing home provisions. This is not an afterthought, okay? So the Ways and Means draft that we just looked at a couple days ago has strike teams, it has dedicated QIO funding for infection control, like Mary mentioned, elder abuse provisions, not an afterthought. Suddenly we're hot, right? We're trending, but we don't have 10,000 likes, that's for sure, quite the opposite. And I think people that don't know any better are pretty easily swayed by a visceral reaction. They'll read a story in the newspaper. That I see outdated kind of preconceived notions of what a nursing home is. In most cases, those are wrong. When I worked for more than 25 years for the Department of Health and Human Services. And I want to say, and I'm embarrassed to say, that a lot of people that work in policy, that work in those offices, work on these issues, but don't have a lot necessarily of experience on the ground in these places. And shame on me, I was one of them. And after coming to Leading Age, I was able to get inside some of these places, and they're not the same as you think. And as Mary said, they're changing. We get really stuck too, I think, on the nursing part. We lose sight of the home part. I think that's a really important thing for you guys to keep in mind. These are homes. Real people live and work in these places. My hope for the work you're doing is that you move us forward as we all try to evolve and remake nursing homes into places that first and foremost really feel like home. Places that are safe, supportive, loving, and help people live their best lives. They need to be great places to work. As a person who works like you, here's what that means. I want to be proud. I want to do something I believe in, surrounded by colleagues that share my values. I want my immediate supervisor to have my back. I want us all to trust senior management because they're transparent with information that matters. I'm fairly compensated for my work, and I want the ability to get better, to move up in my organization if I'm really committed to it. People have built whole careers on solving the recruitment and retention problem in nursing homes, especially related to frontline workers, certainly paying a living wage and giving them some of those things that we all want. It would be a good way to start. And I hope the system that you envision through this work will require and reinforce that. I guess I'm also hoping for the impossible, like how do we craft what you guys are crafting and find enough people, make it attractive enough and find enough people to come and work there. You know, we can't, unfortunately, manufacture people. And then a big part of your long list of problems to solve is financing. We've been at this for decades, for a long time. It is a challenging problem, but I think whatever is the result of your hard work, we need to be sure that we're paying for it adequately. Your charge also is to focus on regulation enforcement. When we first started dreaming about this study, suggesting that, you know, after 35 years, maybe it's time to take another look, and really take a deep look, not just tweaking in the policies that come out of HHS. But when we first started talking about it, I had this image of some construction we did on our house many years ago, and one piece of it was redoing the kitchen, and we had this awful brown linoleum on the floor, and it was a weekend. We were waiting, you know, the people were going to come to work on Monday. Let's rip the floor up. Let's get rid of this brown linoleum. So we took the linoleum up, and what was under it? Blue linoleum. So we took the blue linoleum up, red linoleum. Yep, there were 5 layers of flooring, and then a beautiful wood floor underneath. We have that beautiful wood floor. We have that value, but we have to stop just putting more on top and not taking some away, not reevaluating what we're actually doing, reevaluating the framework. And hey, maybe the wood floor is a good place to start. There's no question. Absolutely. We need regulation. We all pay taxes to ensure that our government does right by people in this country. And making sure that vulnerable older people are getting the best care and supports is part of what we expect from the government. I agree, we have learned a lot from COVID, and we've watched some things happen. One of the stories that I heard in the beginning of COVID was a director of nursing who accompanied an older man with dementia. This was before we had access to tests. Accompanied a man with dementia who had COVID symptoms to the ER. She ended up, because she was waiting, they were waiting there more than 2 hours. And they got cited because she didn't document within the 2 hours and she was off site. That shouldn't happen. We should be able to make the changes we need to make. Anyway, I think in 2021, we are smart enough to use evidence, and many of you guys have produced the research foundation that provides this evidence to create quality measurement that matters. So you tell me how that DON leaving her resident at the ER and running back to the nursing home to quick meet a 2-hour curfew and document what she was doing improves anyone's quality of care or quality of life. Working in a membership association of providers across all settings, I observe that we have trained nursing home providers to follow the rules. So we have people making these rules and people following these rules as rigidly as possible because the consequences are scary and they impede your ability to do your job. And we so often hear from our providers, look, just I really want to take care of these people that I take care of. Just tell me what to do so I'm in compliance. Just tell me exactly what to do. That's not a way to make homes for people necessarily. The best providers that I've met have tied themselves in knots to figure out compliance, but still give residents the space to be who they are. Like, have you ever met somebody that didn't say, well, what's special about me is we're all unique. Each of us feels that way. And we talk about person-centered planning. Well, person-centered planning really means being able to give that to people. Collaboration, not punishment. Mary mentioned this too. I heard a story of a survey team coming in, this was pre-COVID, to visit a resident who was awake but unaware of what was going on around her. And surveyors watched, that she was one of the person they had selected to watch. They watched as every person that came in the room went over to the person and spoke to them and said hello, told them why they were there. And this was everyone, housekeeping, nurses, CNAs, and what they were going to be doing, and then said goodbye. Surveyors watched all this play out, and the nursing home administrator was so proud. Everybody was doing what was in the plan. They got cited for not documenting it. documentation is not the be all and end all. We need to be better also at identifying poor performers. We've been looking at the Casey bill, the Nursing Home Reform Modernization Act, hasn't been reintroduced yet, but it's okay. Most of our members agree it's okay. Find the players that aren't doing it right, find the bad players, and they don't need to continue to provide services, and reward the good ones. Maybe survey the good ones less frequently, maybe let them help each other, like the ECHO model that I'm sure you'll hear about later. Put more of those precious survey resources into the places that need help. I want to also say there's a lot of turnover in survey teams too. Those jobs are just as hard as working in nursing homes, and many of those people are just as dedicated, but then they find out they're coming to work to be a cop once a year in a nursing home. How about if we think about new models for that, and maybe you see each other more than once a year in nursing homes and surveyors. Maybe both of you are part of a team doing the same thing that is focusing on collaboration and making quality better together, not on punishment. The last challenge I want to offer you guys is to not say this dichotomous choice, community, nursing homes, because people cross systems, people move in and out, and they move between systems. People are not a setting, and it's really important. And we don't have a good setting and a bad setting. We have to think of it all together when we think about financing, and possibly even as we think about some of the regulatory approaches. I hope you guys are bold and visionary, and don't add more on top of the regulation enforcement we have today. It really is a broken system. You have the chance to look at it and really make change, really make bold change. And I'll quote Leslie Nielsen in Airplane, where he keeps putting his face in the cockpit and saying, just want you to know we're all counting on you. So heavy responsibility. Thank you again for what you're doing.
And thank you for your comments. Next, Robert Kramer, and we look forward to hearing from you.
Thank you. Thank you, Philip. Madam Chair and members of the committee, it's an honor to have this opportunity to speak before you today. I want to stress that the views I'm going to express are my own. They're not those of the National Investment Center for Seniors Housing and Care, nor of Nexus Insights. I'm going to focus on what to do with the broken and flawed SNF model for long-term care. And I want to say that my esteemed colleagues on this panel and other panels have far more expertise in the details of what I'd call the pieces of reform. So I'm going to also put a lot of my focus on how you might stitch or weave together the pieces, sequencing, what needs to be paired with what, if we're truly going to make progress during this unprecedented moment and improve care and also quality of life. Now, 3 areas I want to address: problems we've got to acknowledge, simplistic solutions we must avoid and their faulty assumptions, and solutions we should consider. First, the problems we have to acknowledge. We have an image and a respect problem. Put simply, we don't value the work that is done in skilled nursing setting. We don't value those that do the work, and we don't, most of all, value those that are the recipients of the care. And that's a huge challenge that society has to face. Secondly, we have a quality problem, and we don't even know what to measure or how to measure. And when we do measure, we measure quality of care and do very little on quality of life, which I would argue is what's most important to the residents, because they are there in their home and they have aspirations. And a lot of quality and care measures have nothing to do with those aspirations. Thirdly, we have a trust and credibility problem due to a lack of transparency. This is a major industry issue that results from limited accountability for how dollars are spent and a lack of confidence that financials truly reflect profit margins. Fourth, we have a delivery of care problem. We have a siloed, volume-driven system that reflects a fee-for-service, curative health model, and that works actually in opposition to person-centered, whole-person care. Next, we have a financing problem. We undervalue and grossly underfund long-term care. And we have perverse incentives that reinforce the wrong actions and behaviors and also often discourage taking the right step for the resident. An example that Ruth just gave. And this includes subsidizing of shortfalls on the care for Medicaid residents with the profit margins on short stay Medicare residents. So we have a siloed and uncoordinated maze. We also have a regulatory problem that burdens the good providers, all too often does not help the poor performers to improve, and often fails to stop and to get rid of the truly bad performers. And we have an infrastructure problem. 51% of our nursing home facilities are more than 40 years of age. 72% are 30 years of age or older. And they're functionally obsolete in that they weren't built for the very frail, complex medically residents of today that are increasingly becoming the norm. And they certainly weren't built, as we've painfully learned, for infection prevention. We also have a labor and workforce problem. As the AARP study has shown us, we have during this very decade we're in, we have a collapse of the traditional unpaid caregiver workforce in that age of 45 to 64. And we have a continued devaluing of the very work of caregiving at a time when we're having explosive growth in the need for caregivers. And we have a litigation problem compounded by COVID. Providers now are bracing for a wave of lawsuits that will drive some out of business, but will increase the cost of doing business, of providing care for everyone else. Now, some simplistic solutions we must avoid and their faulty assumptions. I want to stress most of these I'd put in the category of necessary but not sufficient, because if they're not linked with other measures, the results will be at best frustrating and at worst counterproductive. So, first one, more money is the solution. Yes, absolutely we need more money. The system is badly underfunded, but simply pouring more money into a broken, flawed system will not produce the desired quality outcomes we all want. Secondly, some would say more and tougher regulations and enforcement are the solution. Yes, we must address especially consistently poor performers, either to improve them or to actually get them out of the business. But if we want, and I think we all do, quality of care and especially quality of life and good outcomes, then there's no evidence that simply ratcheting up the degree of regulation and enforcement that's going to lead to those results. Next, some would say increased transparency and accountability are the solution. Yes, I would totally agree. The industry, there needs to be more transparency and more accountability, but not if trial lawyers are going to be the greatest beneficiaries, and the cost of care is going to go up for providers as a result. Some would say wind down the SNF sector completely and put all the money into HCBS. That's the solution. Yes, for those that don't need to be there and for whom we can provide the services they do need, the supports and services they need in the community, absolutely. We should be doing that and moving those folks there. But I think this as a solution fails to understand the extremely frail, complex care resident that's increasingly becoming the norm today in our nursing homes. And then you layer on top of that significant degrees of dementia, making self-care problematic. And I would say here, be careful what we wish for when we embrace that it's best for everyone to age and receive care at home and in their local community, because that can give policymakers, speaking as a former state legislator, an easy way out when funds are scarce, particularly at the scarce level, at the state level. Close the nursing home, but will the dollars really follow the resident into the community and the actual increased dollars per person that you're going to need? I'm not very sure of that. Next, some would say get rid of private equity investors and for-profit ownership, and that's the solution. But wait a second. Who did they step in for? They stepped in as county nursing home owners, and many not-for-profits left the space because try as they would, They couldn't figure out how to not lose money when they were trying to serve this long-term care population. So who's then going to replace and take out the private equity and the for-profit owners? What will be the source of capital for all these aging buildings that so badly need to be either replaced or upgraded? Next, some would say just separate out post-acute care, rehab, short stay, and have a different setting for them from the long-term care, mostly Medicaid population. On paper, that sounds great, but wait a moment. Till we have a new financing and care model for long-term care in the skilled nursing setting, simply pulling out the post-acute care residents will compound the funding and staffing problems for the long-term care residents. Lastly, some would say that winning the fight over and against the other competing voices, what they see as their adversaries often in the sector, whether it's industry providers, consumer advocates, investors, labor, regulators, that solution is the solution. But is it really? Or will the competing voices just cancel each other out in a cacophony of noise that leads to other competing funding priorities outside long-term care, winning policymakers' attention, and our residents being the losers because we each had to beat the other? So lastly, then, what are some solutions we should consider? There are no simple solutions. A complex, multi-pronged problem requires a comprehensive solution, not a finger in the dike approach, which then produces unintended consequences and more severe problems in other areas. But here goes. One, increase funding for long-term care residents in SNFs that is directly tied to improving wages and benefits for frontline staff and meaningful transparency and accountability by providers in their ownership structures and finances. Two, some degree of liability relief for providers so that with full transparency and financial disclosure, the primary winners in terms of dollars are not the trial lawyers. Third, complete overhaul of the current regulatory and enforcement framework to actually provide some freedom for decision-making and a creativity that can drive person-centered whole person care and focus on quality of life that matters most to the resident. Collaboration to improve care, not punishment, should be the norm, and improved quality of life for residents the goal. Next, we need funding and regulation that encourages investment in digital technology in order to drive improvements in areas such as communication, care delivery on site, and resident engagement. We need creative incentives such as buyback programs, but targeted to close functionally obsolete buildings and convert multiple occupancy rooms to single occupancy. We need to promote through regulation and funding household or neighborhood models in SNFs that utilize consistent staffing and even universal staffing. These models perform better in both infection control and prevention and resident staff satisfaction. We need to seek to the maximum extent possible to have integrated funding and care delivery of long-term care and healthcare through integration of Medicaid and Medicare funding and care delivery with a focus on quality of life outcomes, prevention and palliative care versus a curative care approach. Integration of relevant data and data flows is essential, together with encouraging an integrated team approach. Finally, and most importantly, this is a disruptive moment where SNFs and long-term care are center stage in the spotlight. Those of us who care about this sector and those we serve and those who serve them must seize the moment. We've got to be bold, but we've got to, and perhaps the boldest thing, be willing to work together with those that may have been considered adversaries previously, whether again, that's investors, industry providers, organized labor, consumer advocates, regulators. We've got to find common ground, even though this will mean negotiating trade-offs and compromises. The alternative is a cacophony of competing voices again that will make it easier for policymakers and legislators to tune us out, especially at the state level, to fund other priorities where there's broad consensus and agreement as to what needs to be done. And our residents and their staff who serve them will be the losers. Thank you for your time.
And thank you very much. I have never been happier to have had 2 cups of coffee before a meeting. Great ideas. Michael Wasserman, we'd love to hear from you next.
You know, I could listen to Robert all day. It's always a privilege. To paraphrase the historian Toynbee, a society's quality and durability can best be measured by the respect and care given its older adults. Nearly 1 year ago, I said the coronavirus was the greatest threat to nursing home residents that we have seen, and that nursing homes could become our killing fields. My experience as a clinical and quality expert, in addition to having been the CEO of a large nursing home chain, gave me a unique perspective into COVID-19 and how existing structural weaknesses in the nursing home industry would have tragic outcomes. The evolution of nursing homes from post-war rest homes to today's mini hospitals began with implementation of the hospital DRG system in 1983. There was a brief period in which hospitals purchased nursing homes. They quickly realized that they could discharge patients to nursing homes without taking responsibility or accountability for the outcomes. Meanwhile, nursing home investors learned how to make substantial profits from Medicare and Medicaid without regard to quality of care. COVID-19 has unmasked a deeply flawed industry. My comments will focus on two critical issues: the need for clinical expertise and leadership, and the need to address the Byzantine ownership structures that currently thwart challenges to the status quo, whether the challenges come from educators, advocates, or regulators. The average 99-bed nursing home is an approximately $10 million per year complex business. Local nursing home leaders are rarely prepared to run such a complex business. The nursing home administrator is essentially the CEO of the business. What training is required to be a nursing home administrator? What about the director of nursing? They are the chief operating officer, managing and leading an inadequately trained and often poorly paid clinical workforce to provide care for some of the most complex persons in our history. A hospital organizational chart includes physicians at the highest levels. Where is such physician engagement in today's nursing homes? For too many years, the main driver of the nursing home business model has been census. In particular, census of high-paying patients. But census is solely a financial construct. What residents and families are expecting is care. Medicare, Medicaid, and other payers are expecting value and quality. Quality care requires adequate levels of staff who are properly trained. We have more than enough data and experience to know that optimal staffing levels are rarely seen. The other missing element is effective leadership and management expertise. In order to imagine the future of nursing homes, picture a three-legged stool. If the three legs aren't equal, the stool will fall over. The legs represent finance, operations, and clinical services. Rarely at the facility level or the corporate level of a large chain are these treated equally. One will almost never find clinical services being given the same attention as finance and operations. This is the fundamental, and in the case of COVID-19, the fatal flaw in how today's nursing homes operate. If clinical services are not treated equally, the nursing home cannot, and I might say should not, survive. There are people in our society who are unable to be cared for at home. Older adults and younger disabled individuals requiring a nursing home level of care often have complex medical needs. Many have cognitive impairment or dementia. Most persons living in nursing homes need assistance with activities of daily living, whether it be for toileting and bathing or for transferring out of a bed or chair. Meeting the needs of these residents requires an educated and well-trained staff. In addition to the Medicare and Medicaid dollars that fund nursing homes, the Medicare Trust Fund spends over $10 billion a year subsidizing the training of physicians without significant accountability that physicians learn how to care for older adults and disabled individuals with complex needs. Many of us have long sought to geriatricize the healthcare workforce. That same concept must be brought to the nursing home industry. In addition to a properly trained clinical workforce, nursing home medical directors must have the type of training and skills presently associated with the American Board of Post-Acute and Long-Term Care Medicine's Medical Director Certification Program. There are far too many medical directors who lack even basic knowledge of geriatric medicine concepts and who have little expertise or even interest in the complex regulatory framework of nursing homes. At the very least, CMS should publish a list of every nursing home's medical director with their requisite training and certification noted. This will shine a light on the need to fully engage competent physicians in the leadership of nursing homes. Residents and their families have a right to know the identity of the medical director, who, under federal regulations, is responsible for resident care policies and coordination of care. Effectively providing care for a complex group of individuals requires competencies at every level of the organizational chart. Aside from having an appropriate level of staffing, nursing homes require properly prepared, highly skilled leadership teams that can balance the financial, operational, and clinical aspects of this incredibly complex business. Which brings us to a specific roadblock that has prevented us from advancing beyond the status quo. Today's nursing home industry attracts investors primarily because of its real estate and related party potential. As long as real estate is the primary driver of financial success and related parties are allowed to siphon money away from operations, the nursing home industry as a whole will continue to fail to provide value and quality. The COVID-19 pandemic has demonstrated the importance of having immediate access to financial reserves, but those potential funds have been converted into real estate capital and private equity. That capital could have been effectively leveraged to provide for abundant PPE and testing, as well as for additional staff. Instead, for the most part, that capital either sat on the sidelines or was leveraged for other purposes, such as buying more real estate. If we are going to reimagine nursing homes, the clinical operations must have access to these funds. MedPAC produces precise reports of nursing home profitability that are literally based on an illusion. As the GAO has demonstrated time and again, our government's attempts to secure quality and value from nursing homes have been outmaneuvered by private sector accountants and attorneys. We must illuminate and address the structural dynamics that successfully sustain the substandard status quo. Today, in a health affairs blog, we published a set of recommendations to address transparency. The nursing home industry and the government must also fully engage experts in geriatrics, post-acute and long-term care medicine, geriatric psychiatry, as well as experts in the care of the growing younger population of nursing home residents with disabilities and psychiatric conditions. Nursing home policy cannot be effectively imagined or implemented without these experts' active involvement. The more subtle threats to the nursing home industry come from ignorance and arrogance. Ignorance related to the lack of understanding of how a geriatrics-focused, team-based approach to care is essential. Arrogance related to the fact that we can no longer keep running nursing homes as we have for the past 4 decades. If we are to reimagine nursing homes, we must be certain that the clinical focus is never allowed to be subservient to the finances. The entire industry must be reimagined. We must start by assuring appropriate staffing. The staff must be trained and must earn a living wage, and turnover must be reduced. Leadership teams must set their primary focus on providing quality care. We cannot afford money being siphoned out of facilities toward excessive real estate related party and insurance industry profit. The residents we care for deserve to be prioritized. After nearly a year of hell, where all have been cut off from their loved ones and many have lost their lives, we owe them that much. Thank you.
And thank you to all our panelists. We have, thanks to you sticking to our time requirement, we've got plenty of time for questions. David Grabowski, I see you are the first to offer questions.
Great, thanks, Phil, and thanks to all four of the presenters. Those were really great remarks and a lot for us to think about. Both Bob and Mike touched on this issue of transparency, and I wanted to direct my question to Mary and Ruth, and have you both think with us a little bit. We heard a lot at the last public session about transparency. How are you thinking about that from an industry perspective? Bob gave us some unintended consequences, but it seems like if we want to advocate for more dollars, for example, having greater transparency as to where those dollars go would seem to be an important part of that. So that's my question. How do both of you think about that?
Well, from my perspective, I really think that it is critical in all of the areas that Bob has talked about, and certainly within the organization I work with right now, Preparedness Health. One of the very first things that we did when COVID started, and that was in early March, is put up a public-facing website. And I would encourage all of you all to go on and look at that website so that we could keep our patients, our families, the general public knowledgeable about what was happening in our centers. So I think from my perspective, as well as my organization or the American Healthcare Association, we endorse transparency. I think it is time to build trust in this most important profession. I think transparency is necessary.
Other comments?
Yep, sorry, I was muted. I will jump on and agree with all that, and I will point out that the reporting of it takes time, but it's time well spent. A lot of this that we're talking about is government money too, and I think you have an obligation to report that. The other good thing about putting information out there is that there is more information for people to analyze, for people to look at, for people to understand what's going on. And it helps us, beyond just being transparent, helps us move forward because we can use the information.
Thank you. Our next question is from Colleen Galambos. Colleen?
Hi. I want to thank the panelists for their enlightening comments and recommendations. Michael, this question is for you. Some of your comments touched on the qualifications of staff needed to provide adequate care. In that vein, what are your recommendations for how to address holistic care, in particular, the psychosocial care needs of residents and their families?
Thank you. It's a great question. You know, I will make one comment on staff. Whenever I walk into a nursing home, I'm always amazed at how much the staff love what they do. And I actually think if we pay them a living wage and support them, I actually question whether we'll have as many issues as we think we have. And to that point is how we geriatricize. I mean, that really is what it comes down to, is educating and training everyone from housekeeping and dietary, laundry, and CNAs all the way up to the physicians and nurses and nurse practitioners in, the geriatrics approach to care is by its very nature a holistic one. I always tell people, I've stopped more prescription meds in my career than I've started. And so, if we do a better job top to bottom of doing that education and training, I think a lot of these issues start getting taken care of.
One follow-up comment for you, Michael. What about when we look at the whole spectrum of psychosocial care, and we think about activities, directors, social service staff, social workers, chaplains, how do you see those roles play out in the type of care that you're describing?
You know, when PDPM came out, I was actually encouraged because if we take PDPM to its fullest, we have to evaluate every resident and their care needs from a complete global perspective. Sometimes that actually means that clergy person being involved. Sometimes that means more activities. Sometimes it means more nursing. Ironically, my concern about PDPM was that because it was just a dollar amount, that because the system is not prepared geriatrically to understand all this, that the focus would be on bringing the money in, continuing the same old approaches. And crazy enough, I had predicted that we'd be hitting a cliff with PDPM last spring. Never got to find out if that would have been true because COVID hit, and in its own way proved that to be correct.
Thank you.
Can I add on to that too, Colleen? Because
of course.
I think in a post-COVID world, what you're talking about is really going to be important, as if it's not already important. But the way we didn't talk a lot about isolation, but the isolation issues, providers struggle with them. Providers shed tears over the need for isolation, the fact that that's what the year has looked like. We're not just going to emerge. I mean, vaccines are great, and there is definitely a light at the end of the tunnel. But when we come out of the other end of this and people start dining together and people start doing activities and get on buses and go places and visit each other, we are really going to have a need for those services. And just to put a little point on it too, for staff too. There's going to be a need for those kinds of supports for the people that are working there too, who are very traumatized at this point.
Thank you, Ruth.
This is Mary. If I could just add one comment. For the first 11 years of my career, I was a nursing home administrator. And in many days, I think that was the most important experience that I've ever had. I go back to those days now and think about the incredible leadership we had in social services and our activities department, our bachelor's prepared, and just exceptional. Very different patients today, but I will tell you that that is the essence of person-centered care, of knowing your individual. And as an administrator, I made rounds every morning. I came for a hospital, so what else that's what you did. I made rounds every morning. I watched to see what was happening, talked to our residents, and did the same thing before I went home in the afternoons. Talked to the families and all of that. And I feel like that I personally knew what they were feeling, and they could tell me, this is going well or this is not going well, so that we could correct. So extremely important. Thank you for your question.
Thank you, Mary. I come from that nursing home administrator background as well. So I hear what you're saying, and I've been there too.
And let me just add too, if I can, that not only is this important in the areas, just the mental health of residents and staff, but I would also say part of our being so focused on quality of care as opposed to quality of life means we're often not interacting with residents on the things that matter most to residents.
Yes.
And as the age-friendly health system guidelines that were developed, the 4 M's, but what matters most to the resident. And I think we've got to make sure we're allowing the time and the training for staff to be interacting on that, not just on the issue of bed sores and your meds, but on the issue of what matters most to you. What do you want? I mean, I think the phrase should be for everyone that moves in, what do you want to accomplish in your time here? What do you hope to contribute to this community? I don't care what the physical or mental ability level is. We have to shift the paradigm. We have a paradigm that reinforces helplessness and that focuses only on whether or not we're doing all the things that the care requirements that we've got to check off. And that is the antithesis of person-centered whole person care. And we've got to create time, space, and creativity for people to really engage with people as people, not objects of care.
Wonderful. Thank you, Robert, for those comments.
Great discussion. Our next comments or questions will come from Tamara Konecka.
Hi, everyone, and I'd like to thank the panelists as well for some really intriguing and interesting remarks. This question is directed to Bob Kramer, I think, but anybody could jump in on it. And it goes back to the financing and the mixing of Medicare and Medicaid, post-acute and long-term care. As we think about, separation or not separation, I'm always puzzled by a couple of questions about what has been happening, over the past decade or so. When we look at the data, knowing that Medicaid margins are so much higher than Medicaid margins, but when we look at the data at new nursing homes that have entered the field over the past 10 or 15 years, what we see is that they're still doing this mixing, right? That we see a higher percent Medicare and a lower percent Medicaid, but we don't see, given those high profit margins in Medicare post-acute care, we don't see firms that come out and just really specialize in Medicare post-acute care. They're still mixing. And on the other hand, given the low Medicaid margins, we don't see nursing homes that are mostly Medicaid exiting the market very often. So I'm just interested in your explanation from a sort of investor and business standpoint on why that's happening, which could inform, our options moving forward.
Well, lots of good questions, as I would expect from you, Tamara. Thank you. One is obviously there are great restrictions on building new nursing homes. So half of all the new nursing homes in the country, I think, have been built in Texas over the last 10 years. Because there are no requirements and you can build anything, anytime, any place in Texas. That's not true in many other states. A second thing I think is that the challenge is yes, there are kind of recovery spas that are being built that just focus on Medicare. And in St. Louis and Kansas City have been particular places where you've seen that almost become a cottage industry. You're beginning to see some also in Illinois, but that said, you also have a volume issue as well as a payment issue. And so, the volume often comes on the Medicaid side. The payment comes on the Medicare side. And so you play this juggling act. And well, the data with regard to referral rates, hospital discharge rates to skilled are way down and haven't recovered. Whereas in home health, they've recovered and exceeded where they were a year ago. And yeah, there's legitimate concern. Will that continue? Well, that has to do with the volume you're going to get on the post-acute side. And so if you're going to have 80 beds, or you're really with high turnover because of very short stay, are you going to be able to keep all those beds full? Probably not. And so that's why you see this mixing. You get volume on the Medicaid side. I'd rather get 50 cents on my dollar of cost than nothing, empty bed. And on the other hand, I get margin on my Medicare side. And so that's why you see that phenomenon today. There are many other nuances to your really good question, but I think that's a big picture, quick response.
Actually, I'll jump in too, because I think you really touched on something. There's a very small niche market out there for what I call the Taj Mahals, the places that just focus on Medicare and skilled and turnover. But from that niche are also a broader number of places that focus more on the skilled. And then you have the whole bell-shaped curve all the way down to the more Medicaid. I think there continue to be great opportunities with Medicare, Medicaid dollars, with institutional special needs plans that start bringing care and the living situation together. And I think that's going to be a key component of this at the end of the day. I think the complexity of all of the residents, whether they're there for Part A or whether they're there for living in their home, is sort of merging together today. So I think that's why we're having this discussion. It's very hard to separate them, and I think that's why you're pretty spot on.
I have a question that kind of relates to that, and that is what, not everybody who comes from hospital for skilled care goes home. And what do these new places do? I'm sure they're not going to be very popular if they're just sending their Medicaid patients off.
Well, Philip, I think that's one of the reasons some of these places have realized they can't just only do skilled, which is one of the reasons that business model has had its own challenges. Because if they're just perceived as, oh, we're going to come in and take you for your 20 days and then kick you out, that's not going to play real well from the consumer perspective.
Well, in addition to that, that 20 days in the future is going to be 3 days. The reality is the skilled rehab is going to basically, I think, replace the med-surg unit of the hospital in the future. But that's going to be an average length of stay of between 1 and 5 days, not 10 or even 20 days, let alone the 30 in the past. So that means a lot of turnover. That means a lot of, you're filling that one bed many, many times during the course of the year. I also want to add on the sort of primarily, if not exclusively, Medicaid-focused nursing homes not going out of business. That's often because of a sense of desperation by local and state officials. For all the talk that the care is terrible, there's a sense of an outcry if a facility is going to close. We'd almost rather have a lousy facility in terms of quality of care than have, in a sense, all those residents dumped out into the community. And so I do think you see there's usually a concerted effort by everyone to get together to figure out how can we make this work rather than seeing that facility close, because there's a real concern. Because let's face it, many of those folks cannot be cared for as well in a home community setting as opposed to that setting. And if they can, it's going to be very, very expensive. So I think that's another reason. I could cite countless instances where sort of everyone's come together to say, hey, what can we do to help this nursing home stay open? We need them.
And this is, Mary, if I could just add one thing. During this pandemic, the requirement for a 3-day hospitalization stay has been waived. And that has really been a blessing. I would hope that we never have to go back to that required 3-day stay again. But for many of the residents and patients that we have cared for at Pruitt Health, we were able to move them into that skilled care designation, provide the care after they became COVID positive, and avoid the hospitalization, which is a much, much higher risk for our patients, for our residents. So that in and of itself also is really a benefit.
And I wanted to go back to something, I agree with what Mary just said wholeheartedly. I also want to go back to something Bob was talking about in terms of shortening lengths of stay, that this is completely tied up with Medicare Advantage and increasing numbers of people in Medicare Advantage. And not to take you guys too far afield, but I think it does relate as you think about what post-acute care is beginning to look like more and more now. And maybe thinking about integrated models is also another place for you guys to go.
Great, thank you. Our next committee member to speak will be Marilyn Rantz. Marilyn?
I want to go back to the quality of life issue. And Robert, you brought that up quite strongly. And the quality of life measurement issue. I think this is, from my perspective as a researcher in this area, it's something that we really strongly need. And I was struck by your single question, which is asking people what they still want to accomplish as a potential for some measurement. I've run into that before, but I wondered if you had other pieces of advice about potential measures of quality of care that you or others have seen work effectively within this population. I want to make sure that we cover the landscape on this topic.
Thanks. I really appreciate your interest in this area because I just think it's so important. And I just don't want to underestimate the sea change this means and how we think about the residents and how we think about their care. And, you know, again, I come back to what matters to the resident. To me, that's where you have to start. So that does mean in terms of measuring quality of life, resident satisfaction is a key issue. Family satisfaction is another. But I think related to that, questions to my mind are, you know, I've often said, talking about private pay senior living now, that we've gotten too good at asking and putting emphasis on the questions that don't mean anything to the resident. How many chronic conditions do you have? How many prescription medications do you take? What degree of assistance do you need with activities of daily living? And we also do this in the skilled setting. And what's your financial ability to pay? I don't know anybody who wants their life's worth and their identity defined by that. So instead, it's questions along of, you know, what gives you the most joy? Have you experienced any of that in this setting? What gives you a sense of pride and purpose and connection? Has that been encouraged or has that been taken away from you? What, you know, when you moved here, what were your aspirations? I don't care what point of life one is at, and having gone through overseeing the care for a number of different family members and relatives, some with dementia and some with very debilitating physical conditions. No matter who that person is, inside is a person who's screaming, take me seriously. I still have aspirations. I still have hopes. We don't tap into that. And that's what creates satisfaction. And, you know, I could go, I don't want to take any more time, but I've given a lot of thought to the types of questions I think are important. And when we start doing that, we're getting at what matters to the resident. And until we get to that, we're kidding ourselves that we're providing a residential quality of life in terms of a home setting. We're just acting like a hospital. But in this case, we're just waiting for you to decline further and sort of entertaining you with diversion until you die. And nobody wants that.
So Bob once again shows that he could actually be a geriatrician. And you know, it's one of my favorite topics. I think maybe the NIA needs to think about funding more as it relates to developing quality of life, real quality of life metrics that actually work. To Bob's point though, I think things like resident and family satisfaction could quickly be utilized and I think would make a big difference. You know, my favorite example is, do I care from a regulatory perspective whether my residents like chocolate or vanilla ice cream? The real question is, do they like ice cream at all? And we don't ask person-centered questions, person-centered quality of life goal questions the right way. I also agree, Bob's single question of entry is another great example. You can overthink some of these things, and actually there's some very simple quality of life questions that we could probably start engaging and using long before we have, you know, studies to show their value. So I think it's a great question, and I think we must go down that path.
It's a really good question. Who are your friends here? What do you do with your friends here? Do you have some hobbies? What are they? Do you get to do them here?
And this is Mary. You know, I think a word I want to focus on is one that several individuals have said, and that's purpose. If I am alive, but I'm not happy and I have no purpose, am I really? And I'll focus just on an example of one year at Christmas. We all know that the nursing center patients receive so many gifts and baskets and fruits and all those kind of things. But on one particular year in one center, they asked the community to donate all of those things that they were going to give anyway early in November or so. And the center set up a shopping center for the residents to look and buy things or select things, better word. for their families, for their friends. And they were then we got, you know, there was a large party and families and everyone attending where they were giving the gift, not just sitting back and receiving, and they had such purpose in that they were finally, it was the most enthusiastic Christmas I have ever seen in that particular center. And those are some of the small things, but a way to measure, do I have purpose? Is there a reason why I want to keep going every single day? It just cannot be said to be more important.
Thank you so much. Next, committee member Gregory Alexander has a question.
Hi, thank you for your comments. I think every one of you mentioned transparency, and so I have a question about that. And in particular, Mary mentioned that at one point that her organization created a public-facing website to address transparency. You know, we have Nursing Home Compare. I worked with Nursing Home Compare for many, many years, and I think its intention was originally to inform people about nursing homes, but it's become so complex. It's a great research tool, and sometimes a good tool for care coordinators to help with placement and things. But I think some of the intended uses of that website have not been fully realized. So I'm curious, how do you all each think transparency, how is that operationalized? How do you, if you have a public facing website, what's its content? What are the points of interest that you think should be transparent?
So I will start off by saying our website right now is primarily COVID related. Now, we've always had a website and we've always had a lot of information and stories and that type of thing up on our website, but we have educated and have resources on the website so individuals can understand who's COVID positive, what centers have patients in them that are COVID positive, and you know, what's the status of visitation, all of those types of things. And we give actual numbers every day. And then as those statistics change, we have a mechanism whereby we can send out communication to all of our families about what is happening in the center. So we're encouraging, and our CEO has done numerous public service announcements about the website and encouraging the public to use those. We have discussed and we will continue to have this website. We all know that quality indicators and that type of thing that you see on 5-star, they lag behind for months. And so we want to be able to put a really robust amount of information up about the quality of services that are being provided in our centers, staffing, innovative programs that are happening in the organization. So that, yes, Nursing Home Compare is a great resource, but if you look there, then go to our own personal website, look at what we're putting up, and then visit the center and receive that assurance or the information that you need. I think it's critical. It's one of the best things we ever did in COVID. Again, horrible situation, but I think for people to know when they have questions, they seek information. So again, it's extremely important.
I would add that I think that before COVID, transparency was an option for many folks to do when it sort of suited their needs. And it was kind of, unfortunately, also like culture, sort of a warm fuzzy thing that you always have the slogans up on the walls, but do you really live it every day and have a strong culture? And I think what's happened with COVID is transparency is no longer an option. The question has to be on everything. Why not? Not should I be transparent, but why not? Why? Because the whole long-term care and congregate living setting has gotten a black eye, let's face it. And the only way you're going to regain credibility and trust is if you're transparent. transparency is the foundation of building or rebuilding trust. And so I would put it in so many ways. As Mary has rightly said, it starts right now with, okay, how many cases, how many deaths with regard to COVID, staff and residents. It also now, the questions now that, you know, operators are getting, all right, what percentage of your staff are vaccinated? You know, am I going to be, is my mom going to be exposed to staff that haven't been vaccinated? That's a burning question. You know, how are you handling engagement in a time of quarantine for the residents? So there are just some, and then it also goes, as I mentioned earlier, to broader issues that are issues about transparency around how you're using funds. And so it's such that, again, and people can have confidence in where the dollars are going and that you're not hiding dollars somewhere and not really reporting what your real profits are. So for the whole sector and for congregate living more broadly and specifically for skilled nursing, transparency is the path to return to credibility and trust. And I could speak for 5 minutes on about 7 or 8 different categories, Greg, with regard to that, but I can't stress, but it's no longer an option. And because, to put it simply, and unfortunately, but simply, lack of transparency is now viewed as having something to hide, or worse yet, as an admission of guilt. And you'd better understand that. So that's where you're starting from. You're not starting from a blank slate. You're starting from the public assuming if you're not being transparent, you're hiding something.
Thank you. We have a few more committee members with questions, and we're running on up to a hard stop in about 10 minutes. So I'm going to ask David Stevenson to talk next, and maybe we'll try to keep your responses just a little. I may try to keep us moving. Thank you.
Yeah. Thank you very much. And I'll be quick in asking my question. Thanks to everyone for their remarks this morning. So 2 things that were mentioned on the regulatory front, wanting to be collaborative, not punitive, and also targeting resources toward bad actors, maybe surveying those entities more than the better performing facilities. As you know, advocates are not supportive of either of those approaches. So are there reforms, safeguards, compromises that you as an industry can think of that might help advocates feel slightly more comfortable with those types of approaches?
Yeah, I'm gonna jump into something my daughter told me some time ago. When schools are failing, taking money away from poorly performing schools doesn't help. And that is my overall concern about how penalties are applied in the nursing home industry. Now, I've advocated trying to apply those penalties to the financing, the related parties, the real estate, to get them to have skin in the game, if you will, with quality. There may be variations on that theme, but I think we have to be concerned when we take money away as we're trying to improve care.
I would only add that I think I'm sorry, go ahead, Ruth.
I was going to say I agree. And also, hi, David. It's nice to see you. Part of it is that, and part of it is going back to what we were just talking about, which is the transparency and figuring out what is it that people feel they need to know, that, and once they know that, will they feel more comfortable that what's going on, and good measures. I mean, it kind of, you're tying together everything we're talking about, because if we can measure in a way that we all agree is getting us at a truth that we all agree, that, and getting us at better care, better quality of life, better quality of care we can trust. If we can measure it that way, then, and be transparent about it, there's nothing to hide.
Yeah, and I just building on that, because I totally agree with Ruth, what Ruth just said. What we measure is critical. But within that, then, I think 2 things have got to be accomplished. One, we've got to help a community, a facility that's underperforming, and give it a path to improve and help to improve. That speaks to Michael's point. The other thing, though, that I think the advocates are right about, and that is, if it's a bad actor that just fails that test again and again, there need to then be very severe penalties. And they need to not be penalties that stretch, you know, where the process goes on for 5 years and there's 5 years of bad care. And then there's a sale right before the penalty hammer comes down. So yeah, I think the advocates, they want to know that bad actors are going to be gotten out of the space. There's a difference between somebody underperforming and somebody being a bad actor. And I think the advocates conflate the two much too quickly. And therefore they don't get at what Michael talked about. Helping someone that's poor performing in a certain area. Let's do a path to improvement. How are we going to get these? How are we going to get you higher in these marks of these things that matter most to the residents? Because ultimately we're here to serve the residents. And all too often, we're instead serving a quality of care scorecard that doesn't relate to what matters to the residents.
I'm going to move on now, and because I'd like Dr. Jasmine Travers to comment, please.
Sure, thank you. And thank you to the panelists for your remarks. So Dr. Wasserman, you mentioned the importance of nursing homes having access to immediate financial reserves. And it was also spoken about the appreciation of the CARES Act and how those monies had helped. Is this specific to the challenges brought on by the COVID pandemic and the need to have access to funds during disasters and emergent situations and the like? And if not, how do you see this reserve playing out outside of these challenges? Also, can you speak a little bit more about the issue with the capital focus of nursing homes and what can be done to ameliorate this issue? Is it just a means of the transparency that we've kind of been discussing before?
Yeah, the financial resources existed before COVID. COVID just shone a light on it and killed a lot more people than would normally have died from this issue. So I think, that's, actually almost a year ago, I made a recommendation that one of the more interesting approaches to helping the industry would have been putting a moratorium on 2 areas: real estate payments, so leases and rent, and liability insurance. Let the real estate industry and the insurance industry suffer through the pandemic rather than the facilities themselves. They did okay back in the last decade when they got bailed out. So I think that sort of shows sort of the dynamic here of how we use, for example, the CARE Act funds. And we're going to be seeing that in the coming months and years. How much of those funds went directly to frontline staff, went to PPE? How much of it got diverted? And I think, we're gonna learn about that in the coming months. But I think it shines a light on what we're talking about. And as Bob had said earlier, just throwing money at a problem, if you don't use that money wisely, isn't going to help us. At the same time, we need funding to do some of these things as well, as was mentioned by Mary, in terms of making sure that we have the money to pay for the frontline staff and their training.
We have, I'll then turn it over to Betty Farrell, who's got a question as well.
Thank you, everyone. I really particularly want to thank you for all of your comments reminding us about issues of quality of life being so important, and also the many times that you've reminded us that this is the resident's home. And to that end, I did want to ask one additional question, and that is, for many residents, not only is this their home, it is also the home where they will have the end of their life. And so I have not heard any mention today about issues related to end-of-life care or palliative care for residents in nursing homes. I realize that's a big topic of its own that we might need to have the committee devote some specific attention. But while we have each of you as such great advocates, I just wondered if you would like to comment about your perspectives on also improving the quality of life at the end of life.
I will speak to the issue. We certainly use hospice within our nursing centers that concentrate on that, but also I think that comes back to having a very definitive plan of care for every single resident and every single patient, and how they progress or their life changes while they're in the center. but being able to identify, again, the essence of person-centered care, when a patient starts that transition, the care has to change. It has to be not only for the resident, it has to be for the family. Hopefully a family is available. And I think overall, we do a pretty good job in this area, but it is an area where I think we have a lot of improvement that could be made. Hospice, again, very, very valuable, but that should not only be the only avenue.
Thank you.
I think
Betty, I
most
love
of the,
your question too. That's just, and kind of our bad for not raising that. I think probably it was just a matter of time. Advanced care planning has just become so clear in COVID time that we all need to be thinking about that, and that should be part of life. And there's quite a bit of partnershiping that can go on, as Mary was talking about with hospice, but there's also a lot of help. Community hospice is out there providing supports, for example, during COVID, grief supports that are not just about death, but there's just so much loss. And hospice has so much to share and so much to teach in the nursing home space, that the more collaboration there can be between the systems, the better. And it really isn't just about, you know, the last 2 weeks or whatever people end up in hospice. Good question.
and to that, at the risk of ending on a provocative note, so, let me just say that, again, so much regulation is really a watered down derivative of an acute care curative model, which has absolutely nothing to do with palliative care. The people that truly need to be in our skilled nursing setting versus they're only there because they can't get room and board anywhere else, the people that truly need to be there in one way or another, they're already, many of them, in a palliative care situation. That doesn't mean end of life. It doesn't mean they've given up. It doesn't mean that they don't want to accomplish things. But the revolving door that, for instance, the post-acute Medicare payer versus Medicaid payer send them to the hospital because then we'll get them on Medicare again is nuts. And it works exactly against the whole idea of palliative care. And that's one of those perverse incentives. But again, the regulatory environment, that checklist, that's not a palliative care whole person checklist. That's just a watered down version of an acute care checklist. And it has nothing to do with enabling people to age well, age gracefully, and age with meaning in the final days, months, or even years of their life. Get rid of it rather than argue about how tough it could be. Yeah, it's tough on staff, but for the resident, it's taking away quality of life. It's not contributing to it. Let's stop kidding ourselves.
Great, thank you so much. I think in the interest of time, it is time for us to move to the next section. And I just want to also personally thank each of you who have been on this panel for bringing not only your experience and your intellect and your research, but bringing your passion. We've heard from every one of you how much you deeply care about this topic. So thank you to Dr. Sloan and to all of the speakers from this panel. Our next session will focus on oversight and regulatory perspectives. And the moderator of the next session, Assistant Secretary Kathy Greenlee. So I'll turn it over to you, Kathy.
Thank you so much, Betty. I just want to join Betty and Philip in thanking the first panel for all of your presentations and your responsiveness to us as a committee. You can see we're really actively involved in trying to learn and sort through some of this. As we turn our attention to the next panel, we also have a packed agenda. We have more speakers, so sit tight. I want to introduce them briefly. If you want additional information, we have full bios about the presenters on the study website. We will begin with Dr. Sherry Ling, who's the Deputy Chief Medical Officer at the Centers for Medicare and Medicaid Services at the Department of Health and Human Services. Then John Dicken and Karen Walstadt. They are the Director and Assistant Director of Healthcare, the U.S. Government Accountability Office. Followed by that, we'll have Ruth Ann Dorrell and John Hagg, the Regional Inspector General, Office of Evaluation and Inspections, and Director of Medicaid Audits, Office of Audit Services, and the Office of the Inspector General at HHS. And then two final speakers. Toby Edelman will join us, Senior Policy Attorney, the Center for Medicare Advocacy, and Alice Bonner, who's an advisor for care of older adults at the Institute for Healthcare Improvement. A jam-packed agenda. We will run this section like we did the last. We've asked each presenter to speak for 10 minutes. Those of you who are speaking with someone else, we are assuming you will share your time at 10 minutes. Like Philip, I will turn my camera on at 9 minutes to give you a clue that we need to wrap up as we can. So I think we will return and turn first to Sherry Ling. Sherry, do you have your camera on? I want to make sure that
I do.
See you in just a second. There you are. I wanted to just say hello. It's been a long time since I've seen you. Thank you for joining us today.
Oh, wonderful. And really it is an honor to be with you all today. And I will, I see that NAM has received my slide. So if we could just have the next slide, if you don't mind, please. I have to preface my remarks by saying that, of course, my remarks are reflect my own opinions and do not necessarily reflect the opinion of the federal government. I will also add that, as you all know, we are in transition and awaiting a new administrator who will impart their priorities on what it is that CMS works on and addresses. However, with that said, it's undeniable that we will continue all of our work and commitment to solving many of the problems that have surfaced during the course of the public health emergency and the pandemic. And as has been already mentioned very eloquently, the flaws and gaps in our system are readily apparent. And I think I would like to say, to start, even if my remarks are framed in the context of oversight and regulatory perspectives, that I think we come to this together. And thank you, NAM, for convening this, because I think from our different perspectives, we all want the same thing, which is to be able to ensure that the very people who need care and services provided by facilities in a long-term care construct would have access to high quality care and services that really do align with what matters to each and every individual in a person-centered way. So next slide, please. So my remarks are really going to be focused on oversight and the regulatory perspective. Next slide, please. However, just as a reminder, these are just a few of the program and policy levers, if you will, that CMS has authority to take action through. So my remarks really will be focusing on quality and safety oversight, but also quality improvement, as has been requested. And in admittedly, it will be difficult, if not impossible, to address it all in the few minutes that I have. I am not the subject matter expert that can really speak to at a level of depth on the details of the survey process or enforcement. However, I am who's here. So I will make some remarks about where we are and how we have acted during the course of the public health emergency, just to illustrate, as an example, some of these oversight authorities and responsibilities. I will also say that, having heard the conversation from the prior panel, as a geriatrician and a gerontologist, I really would like to enable a system that can meet individual goals of care and also translate and evolve a system from what we see now, which is, into delivering to those outcomes that really matter for people. So what is meaningful? However, I also have to point out that CMS is an implementation agency that our actions and authorities are laid out in statute. And operationally, we need not only the quality measure constructs, but the data sources that would inform the meaningful measurement that was referred to earlier. So we are all in as far as looking at how can we use the data that we gather already, and also potentially contemplate new data sources that inform meaningful outcome measurement. But that is what will need to happen for us to be able to compute cost and quality into value in a way that actually translates into what was discussed earlier. So the next slide, please. Now, we learned a tremendous amount during the public health emergency, and many of the actions taken during the course of the public health emergency were actually summarized in the CMS response to the Commission on Safety and Quality in Nursing Homes that was really charged with identifying improvement opportunities for not only the system, but also how we work and how we implement. So I'm just going to focus as an example on some of the actions taken that are not referenced in this reply, but I would urge this group to look into, for completeness sake, that which was already published and publicly available. Next slide, please. So when it comes to oversight and surveyor actions, reminding all that, I heard earlier the importance of, when we look at the big picture of surveyor functions and oversight, that all cannot be created equally. Not all instances translate into something that goes counter to the purpose of providing care, which is health and safety and quality. But with that in mind, and that time is precious for both those who are providing care, those who are receiving care, and also those who are overseeing care, or the surveyors. So reminding that all here that we did take the opportunity to suspend and reprioritize certain surveys during the course of the public health emergency, and really focused on infection control, abbreviating the totality of items sought and evaluated, and really gave a thoughtful review and rewrite or revision, including those triggers for specific actions, to really focus on infection controls, because that is where we saw many flaws and vulnerabilities that put our residents, our beneficiaries, at risk. And so some of those details are available through the quality safety oversight memos. And this is one of the vehicles that CMS uses to communicate the expectations and provide guidance and clarifications. We also, though, during the public health emergency, and this is something that we really do need to keep up, which is we worked closely with stakeholders, including many of you who helped inform us of what is happening at the front line and at the point of care that is not aligning with the intent of the recommendations, the guidance, and all of the above. So now we also work very closely with our state partners, so not just external public partners, or private partners, but with states to really focus on infection control with clearly delineated timeframes and actions, while also really gathering information as we went to inform and refine our entire process. I will also say that when surveyors are on site, the hope is and the intent is for them to look, even if it's infection control is the primary purpose here, to look for other signals of deficits and suboptimal care, such as if there's been significant declines in condition, immobility, lack of attention to healthcare needs. So all of this information is available on our website, and we've consolidated much of this into a nursing home, single nursing home link, just hearing from from the commission that our information had been scattered hither and yon. So we've tried to consolidate as best we can and keep that updated for the point made earlier of transparency, but also for communication purposes and consistency. Next slide, please.
Sherry, this is Kathy. I've been told you have about 3 more slides. Can we look at them quickly with you?
Yes, absolutely, and thank you. So I did want to also point out that although we are talking about enforcement and oversight, CMS during the public health emergency actually went beyond that role and the role of a payer into the public health space by participating in some of our strike teams. And to the comments made earlier about punitive interactions, this was not that. The purpose here was to go on site, see with our own eyes what was working, what was not working, and how could we help the providers, the facilities to improve. Next slide, please. So the final slide, and I will wrap these two up in a few short statements, which is we have been engaging the assistance of the quality improvement organizations, many of whom I anticipate are on the line or on the webinar, who were part of the information sharing for maximal function of these HHS strike teams, but also much more to enable effective reporting of data into the data collection systems that we help to stand up, but also to use that information for purposes of improvement. And focusing on keeping COVID out, detecting cases early, staffing attention, and also keeping COVID from spreading. So with that, I will actually wrap up and conclude my formal comments and look forward to learning more from you, from the other speakers, and engaging in the panel discussion. Thank you, and over.
Thank you so much, Dr. Ling. All right, we will keep moving. We will hear next from John Dicken and Karin Walstadt with GAO. And John, do you have slides that you'll be using today?
I don't have slides.
We're glad to see you.
Okay, great. Well, and thank you so much to the National Academies and the committee for the opportunity today to highlight key themes from GAO's body of work on the federal oversight of nursing home care. As you noted, also online is Karin Walstadt, who has led much of GAO's recent work on nursing homes, including those overseen by both HHS and the Department of Veterans Affairs. It is an honor to participate with my fellow panelists, the National Academy staff, and the committee members, many of whom have greatly informed GAO's work. I would be remiss if I did not particularly acknowledge one committee member, Bill Scanlon, who earlier in his career was managing director for GAO's healthcare work. Under Bill's leadership, GAO's work on long-term care gained more prominence. And personally, I very much appreciate that Bill first provided me the opportunity to work on nursing home issues about 22 years ago. Much of GAO's current focus related to nursing homes is on the federal response to COVID-19. But as I think Dr. Ling also noted, this recent focus also highlights broader themes. And so I'd like to highlight 4 of those broader themes from GAO's body of work on nursing homes over the last 2 decades. First is the need to continue to improve information that CMS makes available to consumers and to policymakers. Second is the need for CMS to routinely monitor the effects of changes in its oversight process and the evolving long-term care landscape. Third is that too often some homes have had recurring deficiencies or poor performance over multiple years. And fourth is that enforcement actions are often not imposed or implemented even for serious or repeated deficiencies. Let me start by noting that it's been almost exactly a year since one of the first major US COVID-19 outbreaks emerged in the Washington State nursing home. As we all know, and has been referred to today, in the year since, COVID-19 has been devastating for nursing homes. The pandemic has really put a public spotlight on the vulnerability of nursing home residents, more than 112,000 of whom have died as of last month, and nearly all of whom have faced increased isolation and restrictions on visits from loved ones. The pandemic has also posed tremendous challenges on the homes and their staff, with nearly 500,000 nursing home staff also themselves having contracted COVID-19. In response to this unprecedented national emergency, as Dr. Ling highlighted, CMS has taken a steady stream of actions, and I'll not rehash them. She noted some of the key actions that they've taken. GAO's role, we've been tasked by Congress to produce a series of comprehensive bi-monthly reports evaluating the overall federal response to COVID-19. As part of those comprehensive reports, GAO has made 2 specific recommendations in regards to HHS's response in nursing homes. The first recommendation is for HHS to develop a strategy for having more complete data on COVID cases and deaths in nursing homes, which were only voluntarily reported prior to last May. And second is to more systematically plan if and how CMS will respond to remaining recommendations from the advisory commission appointed by former CMS Administrator Verma and released last September. And Dr. Ling also highlighted that there were a number of initial actions taken in response to that advisory commission. To date, however, CMS has not yet implemented GAO's recommendations. I raise these specific GAO recommendations related to COVID in nursing homes because they are consistent with 2 of the broader themes from GAO's longer-term body of work. First is the need to continue improving information that CMS makes available on nursing home quality to consumers and policymakers. The good news is that during the last 2 decades, CMS has made available notably more and better information on nursing home quality. Nonetheless, continued improvement is needed to address gaps and better assure consistency. Relatedly, GAO has often found wide variations among states in nursing home deficiencies cited. This raises questions about the extent to which this variation reflects actual differences in the care nursing home residents receive or differences in the application of the inspection process. A series of GAO reports in 2008 and 2010 highlighted concerns that the extent of serious care problems in nursing homes were often understated. In 2017, CMS implemented long-awaited improvements to the survey process, including more automated tools and additional training for surveyors. However, we continue to see wide variation among states in reporting of nursing home deficiencies, and CMS itself highlights variation among states as a reason to scale their 5-star nursing home ratings within states, not nationally as GAO has recommended. A second theme is the need for CMS to regularly monitor the effects of changes in nursing home oversight. GAO made such a recommendation in 2016. We were pleased that as of last year, CMS demonstrated that it had implemented this recommendation in regards to several issues specifically noted in the 2016 report. More generally, though, CMS needs to routinely monitor to assure that changes in its oversight practices are achieving the intended effects, that longer standing oversight practices remain effective in the changing long-term care landscape, and to mitigate unintended consequences. Let me turn back briefly to some recent GAO work. In May 2020, GAO reported that even prior to the pandemic, the most common deficiencies cited by nursing home inspectors were related to preventing and controlling infectious disease. We found that about 40% of homes had infection control deficiencies cited in each year since 2013, and about half of those homes had these deficiencies cited in multiple years. These recent findings reflect a third theme from GAO's work that I want to highlight, that too often homes have recurring deficiencies or poor performance over multiple years. GAO has repeatedly found that the number of homes with recurring poor performance is notably larger than the relatively small number of homes CMS designates as special focus facilities, the program for enhanced oversight of certain perennially poorly performing nursing homes. At different points over the last 20 years, GAO has estimated the number of the most consistently poorly performing nursing homes has ranged from 416 to 580, while the number of special focus facility slots is much smaller, ranging from about 60 to 150. Further, GAO has found that the most poorly performing homes are not distributed evenly across states. For this reason, GAO has recommended that CMS place more emphasis on the worst homes nationally in selecting special focus facilities, because CMS's state-based approach risks missing many poorer performing homes nationally. A fourth and final theme I will highlight from GAO's work is that even for serious or recurring deficiencies, enforcement actions are often not imposed or implemented. To be sure, as has been discussed, the primary goal of nursing home enforcement is to prevent or correct problems before they result in further risk of resident harm, not to be punitive. CMS has a range of enforcement tools available, some of which are rarely used. Even more commonly used enforcement tools, such as fines, are often not imposed or may not ultimately be implemented. Let me illustrate this with two very different examples from GAO's recent work. As I just noted, infectious disease prevention and control have been the most frequently cited category of deficiency. However, only about 1% of these citations resulted in enforcement action, in large part because they were usually cited at lower levels of severity. At the other extreme, in 2019, GAO reported that deficiencies cited for physical, mental, or sexual abuse of nursing home residents were relatively rare, less than 1% of all deficiencies. But abuse deficiencies had doubled in frequency from 2013 to 2017. And particularly concerning was the largest increases occurred among the most serious levels of severity. Yet we found that only about 8% of abuse deficiencies result in implemented enforcement action. In closing, as the nation hopes to turn the corner on COVID-19 in the coming months, with nursing homes prioritized for vaccine administration, it will be particularly important to assess lessons from this unprecedented emergency on how to better assure nursing home residents' health and safety going forward. Key among these will be identifying lessons for better preventing and controlling infectious disease, assessing the effects from having suspended most comprehensive nursing home inspections and many complaint investigations, and addressing the further isolation from loved ones that many residents have experienced. I hope that the themes from GAO's work that I highlight today are helpful to the committee as you continue your work. Thank you.
John, thank you so much for your testimony. I want to acknowledge your shout out to Bill Scanlon, and like you, we're thrilled to have him on the committee with us. So I do want to acknowledge his presence among us as we do this work. All right, we will keep moving to our two colleagues from the Office of the Inspector General, Ruth Ann Dorrell and John Hagg. I don't know how you all have divided up your presentation, but we're ready to hear from OIG.
Thank you, Kathy. This is Ruth Ann Doral. I'll be starting us out and then pass to John. We really appreciate the opportunity to speak and connect with all of you. Many of you we know and some we don't. We would love to continue the conversation. Hope you'll reach out to us on anything that I mentioned. We're always so open for suggestions. OIG provides oversight of HHS programs, and it's critical to us that we hear from those in the community and have ongoing conversations. John has been with OIG for 31 years and me for 26. And so also, if we can provide any additional information to you, we'd be so happy to do so. If we don't know the answer to something, we probably know the person who does. We have expertise across our organization. Our New York Office of Evaluation, for example, has just decades of expertise in long-term care, particularly hospice and end-of-life care that several of you have mentioned. So happy to serve as a resource. So I'm representing the Office of Evaluation and John, the Office of Audit Services. He's the director of our Medicaid audits. And not represented are two other components, the Office of Counsel to the IG. Our OSIG handles fraud and abuse cases, program exclusions, corporate integrity agreements, the attorneys. And then also our Office of Investigations does extensive nursing home work, investigating fraud and misconduct and working with the Department of Justice. Our investigators are also in the field quite often. And I wanted everyone on the call to be aware of a brand new effort that they've launched called Operation Care. You can find it on the HHS OIG website. Our investigators were finding an uptick, a spike in reports of harm and neglect during the pandemic. And so in frustration over that, they launched an education and outreach campaign to better inform residents, family, and staff how to report quality of care concerns. We found over the years in our work that sometimes people don't know what to do, how to report. There are, of course, many different ways to do so. And so our investigators launched this effort, and they personally visited hundreds of nursing homes and have also contacted over 100 nursing home and elder care advocacy groups telling them about this effort. And we would love for you to go online and find more about that and the materials, videos that they've produced about reporting problems with quality of care in nursing homes. So our work in evaluation has uncovered over the years widespread problems in quality of care. We've been focused over the last decade largely on resident care and on staffing. Something that Ruth Katz mentioned earlier that I wanted to harken back to, we so agree how important it is for feds like us, policy wonk like me, to be on site in a nursing home. It really is different when you're there in person. We can't always pull that off. We often have to rely for our research on administrative data like claims data and medical record review, but we go as often as we can. A lot of our emergency preparedness work and our adverse events work has required us to actually go on site to facilities, and I couldn't agree more how critical that is to talk with medical directors, directors of nursing, frontline staff, and so forth. We also spend, of course, a great deal of time talking with CMS, with GAO, and with advocates like Toby, I think I spoke with earlier this week. So a couple of highlights from our past evaluation work. Probably our most well-known work was a study that we did to look at the incidence of adverse events, patient harm in skilled nursing facilities. We found that 33% of residents were harmed as a part of their SNF stay. And we made the supposition that that was even probably more true for those who were in long-term care stays. And the interesting thing about that study was not just the high harm rate, which is just crushing, but also the fact that most of the harm was very subtle, that it was a result of daily care, daily substandard care, one thing sort of leading to another, to this cascade effect. For example, days of dehydration leading to kidney damage. Whereas when a lot of people think about adverse events, they think about a medical error, some kind of active thing like the wrong medication, when really we just found that it was often a buildup over days and weeks and months. And so we made some suggestions to CMS and recommendations about improving measures, and that's also what led us to our focus on staffing. So many of the adverse events were due to lack of monitoring and low staffing issues. So in 2020, we produced a report that may be of interest to you on the data in the payroll-based journal, looking at how some of the homes were erratic in the data that they produced. Sometimes the data that we found didn't match the star rating. And we're following that work up with another study this year to look at CMS action to ensure the quality of that data. And a couple of other things that we're looking at further at the CMS use of infection control surveys. We produced a report in December 2020 that found that few deficiencies were made or were cited during these infection control surveys, and made recommendations to CMS about that and about considering revising the survey. And then we also have some exciting work coming out in the next month or so about state survey agencies and looking at the survey agencies that are routinely poor performers year after year, are not able to conduct surveys timely, and how CMS has used remedies and sanctions to try to create improvement in that performance. John, I'll pass it to you to talk about our audit work, and then of course happy to answer any questions.
Great, thank you, Ruth Ann. As Ruth Ann said, my name is John Hagg. I work within the audit component of the OIG. I have for a long time, as Ruth Ann mentioned, for about the past 20 years or so. I've really focused on audits of the Medicaid program. It goes well beyond work involving nursing homes, but we do have a body of work that focuses on quality of care in nursing homes. One, because a lot of Medicaid beneficiaries receive services through nursing homes, and Medicaid pays billions of dollars to nursing homes. So it's always a little bit of the body of work that we perform from an audit standpoint within the OIG. There were three bodies of work that I thought I would cover here today, work that we've completed over the past several years, and I thought I would just highlight it. Focuses on nursing home quality of care. The first area is a series of audits that we performed that we've completed in 7 states that focused on nursing home life safety and emergency preparedness. Now, the life safety part really focuses on nursing homes being prepared to prevent or deal with fires if they occur, and emergency preparedness really focused on facilities being prepared to deal with natural disasters, hurricanes, floods, and the like. We conducted the work in 7 states. We've looked at 20 facilities in each state. By and large, across all 7 states and most all of the facilities we looked at, we did identify compliance issues involving both life safety and emergency preparedness. Just as example with life safety, just instances, and these are just some common examples. Fire doors that were blocked or wouldn't close, missing or damaged smoke or fire barriers, problems with sprinkler systems, with non-compliance issues involving emergency preparedness, just not having emergency plans in place, and some issues involving backup power supplies not being tested or not being in good working order. We issued our reports to the state agencies. That's how we normally operate. The reports will go to the states, and we'll make recommendations that focus specifically on the facilities we visited, or more broad recommendations on what we think the states can do to try to help improve compliance at the nursing home level. The second area involves nursing home reporting of potential abuse and neglect. We've completed work in 2 states. I mean, best case would be that in a perfect world, there's never abuse and neglect in nursing facilities. But when abuse or neglect does happen, we wanted to check to make sure that, one, it was being reported by nursing facilities to the appropriate authorities and then being investigated, so those types of problems wouldn't repeat again and again. We've conducted audits in 2 states. Both of the states, we found a few examples where incidents of abuse and neglect were not reported, but by and large, most of the incidents we identified had been reported, and we were glad to see that based on similar work we've performed in other settings where the reporting rate wasn't as high, and so that was a positive thing. And then the last area I'll cover real quickly is it focused on nursing facility correction of deficiencies. Clearly, again, be great if deficiencies never occurred in nursing homes, but when they do, we wanted to check to make sure that they were being corrected in a timely manner. Looked at 9 states, Two of the states did a great job of ensuring that past known deficiencies were corrected, but 7 of the states did not. There were many examples where the state agencies did not know if the past known deficiencies had been corrected or not. So really the work for all 3 areas focuses on trying to ensure compliance with existing rules that are out there. Nursing homes, state agencies, they have a tremendous challenge in trying to make sure they're in compliance with all the rules that exist. But based on our work, we have identified areas that need some improvement. And so with that, I'll turn it back to the moderator.
Thank you so much, Ruth Ann and John. Thank you for your presentation. Thank you for the work that you do. We will keep on moving to Toby Edelman. So Toby, if you would appear and give us your comments, please.
I did. I put my video on.
There we go. We see you. Hi, Toby.
Okay, fine. Thank you. Thank you very much for the opportunity to speak with you today. I would like to discuss some of the issues that I addressed in a statement that I submitted to the committee on January 13th on behalf of the Center for Medicare Advocacy, where I work, California Advocates for Nursing Home Reform, and the Michigan Elder Justice Initiative. But first, I want to endorse the comments of my fellow advocates and representatives from PHI and SEIU at the January workshop. They spoke about the desperate need to increase nurse staffing at facilities, both professional and paraprofessional. We have known for decades, literally, that nurses are critical to quality of care and quality of life for residents. The pandemic has just reinforced our knowledge, as study after study documents that residents are less likely to get or to die from COVID-19 if there are more nurses in their nursing facility. The New York State Attorney General wrote in her recent report, Nursing Home Response to the COVID-19 Pandemic, that New York City facilities with the highest staffing levels had half the death rate of facilities with the lowest staffing levels. She concluded, quote, staffing was more determinative of death rates than COVID-19 geography, close quote. As we suggested in our statement last month, the structure and framework of the 1987 Nursing Home Reform Law are sound and do not need to be revisited, except for the need to add more meaningful nurse staffing standards. The other change I strongly recommend and urge this committee to endorse is reversing the dismantling of enforcement that occurred during the last administration. The standards of care and the survey process to determine compliance with those standards are to a large extent meaningless if facilities face no consequence when they are cited with deficiencies. At present, very few deficiencies lead to any financial penalty. The GAO reported in May 2020, as Mr. Alexander just described, that in the 5-year period between 2013 and 2017, 40% of facilities were cited each year with an infection control deficiency. Yet there were no financial penalties for 99% of these deficiencies. The enforcement system is not punitive. What I want to focus on in my remaining minutes is 2 key questions. Who owns, operates, and manages nursing homes, and how do they spend the public reimbursement they receive? Since the Institute of Medicine issued its groundbreaking report in 1986, which was legislative history for the 1987 Reform Law, ownership and management of facilities have dramatically shifted. We have fewer mom and pop owners who own the business and property. Instead, multiple limited liability companies take pieces of the job. With multiple companies, it is difficult, and intentionally so, for government and private parties to hold facilities accountable for poor care. Use of multiple companies also creates opportunities to hide profits. Increasingly, private equity firms and real estate investment trusts, not healthcare professionals, run the country's nursing homes. And companies have emerged from nowhere to take over facilities, often from multi-state nursing home chains that decide they no longer want to operate facilities directly. States and the federal government stand by, either lacking the legal authority and tools to address these ownership and management issues, or ignoring their statutory and regulatory oversight responsibility. Here's an example. In the spring of 2018, the New Jersey-based Skyline Healthcare collapsed and abandoned facilities that it had taken over across the country in little more than a year. States installed temporary managers or rushed to court to get receivership so they could pay staff and vendors and make sure residents had food and medication. On April 27, 2018, Pennsylvania installed a temporary manager at 9 facilities operated by Skyline, although it declined to identify the manager. The Philadelphia Inquirer reported that Skyline had leased these facilities from Golden Living, quote, which in 2016 and 2017 exited nursing home operations nationwide in favor of owning the real estate, close quote. As reported on May 5th, Pennsylvania identified a new operator of the Skyline facility in Lancaster, a new for-profit company that had been created 3 days earlier. The so-called new operator was not actually new. It had at least 2 of the same owners and shared the address of a company, Priority Healthcare Group, that had bought 12 of 14 facilities in the state in 2016. Priority's record managing 11 of these former Golden Living facilities was poor. Priority cut staffing levels and reduced other spending. Yet this so-called new company that Pennsylvania entrusted with the former Skyline facility. The New York State Attorney General's recent report also described the business model of many for-profit facilities that leads to low staffing, related party transactions, self-dealing, and poor care. The Attorney General calls for more transparency. While transparency is necessary, it is not sufficient. Transparency reflects a market-based model that says, we'll give you information and you decide where you want to go. But many people who need nursing home care can't really decide which facility to go to. They're often in a hospital and told Medicare will not pay for more care. They must leave immediately. In 2007, the New York Times reported more profits and less nursing in facilities owned by private equity firms. In response to the Times' expose, Congress enacted transparency provisions in the Affordable Care Act, but we need more. We need enforceable laws and rules defining who is eligible to own and operate facilities so that deliberate efforts to hide ownership and control are not permissible. New York, by law, prohibits publicly traded corporations from owning or operating nursing facilities in the state. States have much broader authority than they typically exercise. A related concern is that as companies buy more and more facilities in a state, they become too big to fail. They are too big for the state regulatory agency to enforce standards of care. Years ago, I heard a speaker from Texas describe how the state had to scramble to take over maybe half a dozen facilities that the owner had abruptly abandoned. How much more difficult for the state to try to deal with 50 facilities or more under common ownership. States simply don't have the resources to take over management in a time of crisis for so many facilities. The result is that poor quality of care is allowed to continue unchecked. Owners become even more brazen in their defiance of rules. My second major concern is how facilities spend the reimbursement they receive. Here's an example. On January 20th, 2021, the Washington Post reported that Genesis Healthcare's CEO retired on January 5th and received a bonus and consulting contract of nearly $1 million. Less than 3 months earlier, he had received a $5.2 million retention payment. The Post reported that the Genesis Board of Directors, quote, also decided in October 2020 to put aside $2.1 million in a trust the company described as beyond the reach of creditors to be used for bonuses for 7 of the company's high-ranking officers, close quote. Even as the company was reporting that it might soon be filing for bankruptcy, it continued to receive considerable additional federal and state funding during the pandemic, hundreds of millions of dollars, at the same time that its more than 300 facilities reported more cases of COVID and more deaths than comparable nursing home chains. The Genesis story provokes outrage, but we have known for many years that facilities spend their reimbursement however they choose. In a June 2002 report entitled Nursing Homes, Quality of Care More Related to Staffing Than Spending, the GAO found that national expenditures increased from $53 billion in 1990 to $92 billion in 2000, just 10 years. What did we get for this additional money? The GAO looked at 3 states with dramatically different Medicaid rates, Mississippi, Ohio, and Washington, and found that the percentage spent on staffing was basically the same across the states. Facilities in states paying higher rates did not increase their staffing levels. They spent the money elsewhere. I urge the committee to recommend that Congress and states enact a direct care ratio to require facilities to spend designated portions of their reimbursement on care, and to set and enforce, through audits and sanctions, firm limits on how much can be spent on administrative costs, management fees, and profits. Again, this recommendation is politically doable. New Jersey just enacted a direct care ratio, and Congress enacted a medical loss ratio for Medicare managed care programs in the Affordable Care Act. The nursing home reform law obligates the secretary, quote, to promote the effective and efficient use of public monies, close quote. Taxpayers have a right to direct how public funding is spent. Limits on how facilities are able to spend the public reimbursement they receive, with audits and meaningful enforcement, could also operate as a self-regulating check on ownership. Different companies and owners might choose to own and operate facilities if they knew they had to spend designated portions of their reimbursement on care, and would be identified and sanctioned if they didn't. The pandemic has brought to greater public attention than ever many longstanding problems in nursing homes. This committee has the opportunity to recommend meaningful changes that will ensure, as the reform law promises, that residents receive the highest possible care and that public money is spent appropriately. Thank you.
Toby, thank you so much for your comments this morning, for joining us. We appreciate it. We will have our last, but certainly not least, presenter for this panel, Alice Bonner. We are looking forward to hearing from you.
Great. Thank you so much, Kathy, and good afternoon, everyone, or whatever time it is where you are. It is an honor to be here with the other speakers and with all of you. I'm the wrap-up person, so I'm gonna try to weave together some of the themes that you've already heard, not because we got together ahead of time and planned it that way, but you're gonna just get the sense that independently, a lot of us thought about the same themes. So I wanna talk about three things, three topics. First, that all of you and all of us need to hear the voices of people who are working in nursing homes, people who have worked in nursing homes, the voice of residents and their care partners. Second, we must create and support better roles for certified nursing assistants, or CNAs. They're asking for it. We've heard about it. You have as well, and we need to go there. And third, as you've already heard today, we need to look at the survey process and regulations and figure out how we can do more to improve quality of life of residents in nursing homes. So if I circle back to my first comment, so I started out, I didn't know anything about nursing homes, nothing about nursing. I was in college and I ran out of spending money. So I got a job as a nursing assistant. You didn't have to be certified back in 1977, 78. And so I walked onto the floor, and again, not knowing anything about the environment, I had a CNA who was orienting me, and she taught me things like to take a bed sheet and stretch it corner to corner and whip it around in the air until it was like a rope with a big bunch of fabric in the middle. And she taught me to put it through a resident's legs under the wheelchair and then tie it in the back of the wheelchair. And this was a time when very few people were up walking around. Most people were in wheelchairs. They had physical restraints. And, you know, then we wondered for a long time why there was such a high rate of pressure ulcers in nursing home residents. And we know there's a lot of factors contributing, but fortunately that practice has mostly gone away, we hope, in just about all nursing homes. I was also taught that at mealtime, you know, we would line people up at the nurse's station against the wall, and in their wheelchairs, we would bring their trays, plastic trays, and I was taught to give people a mouthful at a time as they were lined up, 1, 2, 3, 4 mouthfuls. And that's just not a way that probably any of us would say we'd want to enjoy a meal or would enjoy a meal. So thankfully, a lot of those practices have also gone by the wayside. But it's important to know how things were years ago, because those were the standards of care. And nursing homes were not cited by surveyors for things like that. So I wanted to bring today two name tags, and I bet you can't probably see them all that well, but these are two name tags that I always keep close by. And this one has Alice Bonner, PhD RN on it, and it's my current one. And I'm proud of those initials. I worked really hard to get those degrees. But this is the one that really, really matters to me. again, you probably can't see it, but it has my maiden name and it says Nurse's Aid, and it's on this sort of cheap piece of plastic. The first name tag I ever had in nursing homes. And I keep it in my desk drawer so that every time I open my desk, I see that name tag and I remember why I went into this work and why I care so much about nursing homes, residents, nursing home staff. And I know a lot of you started also as a nursing assistant or in a similar role, and you probably have stories that you can share as well. So those things are really important to me. If we talk about now going to current times and present day, and we think about certified nursing assistants, again, they spend the greatest number of hours every day with residents. They know things about residents that no one else on the team can know. And they're telling us that, yes, it is about wages. And you heard other speakers talk about that. The wages are not a living wage in most parts of the country, $12 or $13 an hour, limited or no benefits, unsteady hours that get cut, all of those things. But CNAs will say that's not the big issue for them. It is that, plus it's that they don't have a career trajectory. They don't have an opportunity for career development as a CNA. And yes, some people go into the field and they want to become an LPN and they want to become an RN. We need to support that. We need programs that do that. But a lot of CNAs tell us they want to become a lead CNA. They want to run self-directed work teams. They know how to do that. Give me a chance. I will show you. They want to become a trainer and train more junior CNAs. And these programs have been tried. There's apprenticeships that we know about and programs that have been tried but have run out of funding, so they no longer exist. But we can go back and find and do those things. So what could we do starting tomorrow? What could we do starting next week to really get going with this? Well, we can look at the requirements for CNA training. They're pretty general. They're not really detailed. They're not really robust. So we can look at the requirements for that. We can make sure that priority topics, you just heard some great information about infection prevention and how we need to do more with that. That's an example of right now we're in this COVID-19 pandemic. We need to have information for CNAs about that. We need to make sure that we're not just pushing content out, but that we're talking about processes and systems, again, how teams work together. And finally, it's critical that we incentivize nursing homes so that nurses and social workers, pharmacists, and medical directors are all working along with CNAs, and they are, part of an interprofessional team, and everybody is equally valued on the team. So support from nurses and other staff members is critical. So you heard me talk about CNAs, and now I'm going to talk about regulations and the survey process. And again, I'm speaking to you primarily today as a clinician, a nurse practitioner for many years, but also someone who has done policy development and has overseen a survey agency in a state and has worked with all of the survey agencies when I was at CMS. We've had significant improvements in the survey process over the years. You heard Toby mention about OBRA 87. We have the CMS National Partnership to Improve Dementia Care that Dr. Lang and I worked on. We have surveys that are now required to be done off hours, on evenings, on nights, on weekends. I have been on survey teams and done those surveys on off hours. And it is really pretty dramatic what we can find and how we can work together to make improvements. So we've had improvements in the survey process. We've had improvements in regulations. What else could we do? First of all, we need to figure out, and someone else said this already today, how we get really good, dedicated people to want to become surveyors. This is one of the most important jobs in healthcare, and it's critical to people who live in nursing homes and who work in nursing homes, and to the care partners in the community. So how can we recruit really good people who are RNs and social workers who could make a lot more money doing something else in a lot of states? How can we incentivize them? How can we look at the survey and training process? How are we training surveyors? You heard a fair amount about that. You heard about the GAO, the OIG, and CMS and HHS all working on this. What else could we do? And again, how can we continue work that many of you on this group are already doing and move forward, again, starting tomorrow? So in wrapping up, I would say the three things: we must look at supporting CNAs. We must look at the survey process, and we must continue to hear from people who have done many different things in their careers, including people who've been at the point of care in nursing homes. And I just brought one other thing to show you today. If you can see it here, it's one of my most cherished possessions. It's Notes on Nursing by Florence Nightingale. And I'm sure you're saying to yourself, why is she showing us a book that was written in 1859, a century and a half ago? Like, what's the relevance here? You've heard about some of this today already, because if you read this book, and I encourage all of you to look at it, even whether you're a nurse or any other profession, Florence talks about things that are applicable today during the pandemic that we're talking about. Open the windows, fresh air, air circulation, good basic nutrition and hydration, daily exercise, getting outside, taking a walk. Those are public health principles. And you heard Bob Kramer, if you heard the first panel, talk about age-friendly health systems. It's in this book. All of the things that we talk about today, so many of them are here. So I would say going back in history sometimes does have value, and I believe in it. So I hope you'll pick up that book. I wanted to show you, I've got my sleeves rolled up. I came with my sleeves rolled up today because, like so many people on these panels, I'm sure I speak to many of my colleagues also, that we are ready, willing, and able to work together on improving quality in nursing homes. And we really value the work that all of you do. So thanks for having us, and I look forward to the discussion.
Thank you so much, Alice and rest of the panel. As you can tell, if you were here earlier, we have an active committee that will have lots of questions. Alice, don't go away. I'm going to take this moderator's prerogative and ask you a question as we develop a queue. I believe when you and I first met, you were in charge of special focus facilities at CMS. Am I remembering that correctly?
We had a team, but I was the director and working with that team, yes.
So do you have any insight for us on special focus facilities and that program in ways that it could be strengthened? A couple of the speakers today have mentioned it. I think there's been some reports on from Congress, I think, on whether or not it's sufficient. Because I know you did that work, I wanted to ask you before we turn to the rest of the committee.
So the number of special focus facilities for each state is a small number. It has varied a little bit, from state to state, depending on a number of factors, but the program was designed to really increase the attention and focus and development at a few facilities that struggle year after year after year, and try to figure out together how they can improve. The data on special focus facilities and how well that program has actually worked in terms of outcomes has been, I would say, variable. And some of the people who are on this committee have actually published on that work. And I think from my experience there at CMS that we really could provide more resources, not just for surveyor training, but to programs like this, so we could have the increased focus and attention and work together for more of the organizations. I know our colleague from GAO talked about how there were somewhere between 400 and 580 poorly performing nursing homes, and yet only 60 to 150 special focus facilities. I think that's a telling statistic, and it tells us there's probably 580 nursing homes maybe that could really use additional support. So
thank you. All right, I'll let other people ask questions. Jasmine Travers, I'm going to call on you next.
Thank you, and thank you to all the panelists for your remarks. I wanted to just start off, there was a special focus on poor performing facilities, and wanted to understand a little bit more what that looks like, especially when thinking about understanding what these poor performing facilities look like. High percentage of Black residents, high proportion of Medicaid residents within the facilities, or nursing homes within rural settings. That's my one part of my question. And another part is CMS in October announced that they would place a special focus on certified nursing assistants and turnover among those staff. So wanted to hear a little bit more about the plans for that.
Do we have a panelist who wants to be responsive?
I think, I don't know, Dr. Ling, if you want to respond to that.
Sure. So let me start with some of what our focus was in addressing staffing. And certainly, you know, the data and the payroll-based journal data source has continued to flow. So that, you know, the purpose of that is making that publicly available for purposes of transparency and for use in looking at what is reported by facilities. I will also say, you know, some of the flexibilities that we imparted during the public health emergency did focus on, the intent was to be able to bring into the field clinicians with more on-the-job training and ease the access so that we could create some resiliency of the system. Now, one challenge that we're having is that, you know, particularly in light of surge, some of those surges, I mean, when a city or a region is surging, it's happening to everybody all the time at the same time. So we understood that there's some, you know, pulling from one facility type to staff another, and therein lies in itself a problem for infection prevention. So what our approach was to really, you know, work with the local entities to say, you know, please coordinate, please talk to one another, hospitals, connect with nursing facilities. And we've been very, very supportive of the Project ECHO type of model where there would be all teach, all learn, all staff together, but still maintaining those infection prevention principles. So this is still work in progress, but here's where the data really, really matter. Data on, and for us, we've still been supporting the data submission into NHSN for events, outcomes, resources for by nursing facilities for this very reason, and making those data available for multiple purposes. Hopefully that helps. And Alice, I'm sure you have more to add on that.
I was going to add to all of that, you know, we heard from some of the speakers on this panel and also the earlier panel about, you know, about joy in work and about, you know, how teams function and people getting support and not being in a hierarchy where, you know, there's a constant stress and strain between, you know, nurses or even senior leadership like the director of nurses and the administrator and people who are direct care workers. There are scientific studies about that, and it's really important that we consider how do we build positive relationships and how do we make the rapport among team members better. And again, people on the earlier panel talked a lot about that. This cannot be where the survey process focuses too much on things that are important, but not what matters to the resident. So is the temperature of the freezer important? Of course, we don't want people to get food poisoning. So yes, we have to look at that on survey. But if we miss the opportunity to talk about what matters, if we don't ask people what gives you joy, you know, how do you get through your day here? What do you like doing? What are your hobbies? If we don't have a way of getting at that information, then we're not measuring the right things on survey. And Dr. Rantz asked a question earlier about measurement and are we measuring the right things? So I think it's a great point. And as we think about this, if we're taking an 800-page manual for survey and we're saying, well, what could we do? We can't tackle this whole 800 pages. Pick 3 things, and this could be one of the 3 things that we pick. Is we could look at what matters, what's important, how we figure that out, and then tie that back to the survey process.
Thank you. I think what I was trying to get at, this is huge that CMS says this is what we're focusing on, right? And there was this press release that turnover among CNAs is a huge issue. And this is where we're going to kind of, I guess, put our money forth. So just wanted to know, is there any actionable steps that have been developed in the meantime to go towards increasing staffing among CNAs and decreasing turnover? Because that's been something that's been communicated across the board here and previously about the need to support CNAs and increase staffing and training and all that goes with that.
Yeah, so let me answer it in this way. So we have taken a different approach to training that really then focuses more on the frontline clinician and including CNAs. So those tools are also available. However, I think the point of your question, I really appreciate, because so our ability, so the CMS ability to actually be more prescriptive is to some extent limited, because what we have is numbers, right? We have the numbers that have been reported. There are some facilities that would, and not all numbers are created equally. So how do we refocus the question on how do we have the team in place that delivers to the needs of the person who is being served? And thus far, we really are focusing on, all we have is staffing, and we have the information that comes to us through MDS. But I think it's an opportunity to ask the question, so what other data do we need that could be useful to address the question of making the responses and the care more aligned with what individual residents want and need. So again, aligned with their goals of care. And I will also say that one of the challenges that we have, and I've heard it said in the earlier session, that there's a lot that is insisted upon in maintaining infection control that is less meaningful to, quality of life, if you will. I'm hoping that we can do both, not just either or. But one of the challenges that we have is that, because of the Medicare payment focuses on reasonable and necessary for the management of medical conditions, that can be interpreted in a way that really we need to build the bridge towards what is meaningful for the people who we serve. I think we can get there and do both, but I don't think that they're in direct conflict, but it is going to be work ahead of us. Over.
Thank you.
Kathy, I'd like to speak to some of the staffing issues.
Just a second, Toby.
Sure.
I just want to tell it. So Lisa Kaplasky, I've got you and Colleen in the queue next for questions. So I just want to know I'm keeping track. But yes, Toby.
Okay, we just heard from Alice how she started as an aide. There was no requirement for training, and she just followed around another CNA who told her practices that we now know are really not good at all. The 1987 reform law required training. Half the states did not require training. But what we've seen in the pandemic is a dumbing down of the CNA position. One of the waivers that CMS put in place in March 2020 was a waiver of the requirement that aides get training and be competent before they provide care. The law says they can't work for more than 4 months. What immediately the Nursing Home Trade Associations did was come up with an 8-hour online training program, and these are temporary nurse aides. A number of states explicitly allow temporary nurse aides to provide care. We have no idea of how many there are, what they're doing, how they have been trained, whether they have the competence to provide care to residents. And we're very concerned about what happens when the public health emergency is lifted and what happens to these people. I think the advocates would say these people need to be trained. They need to be fully trained in the state's program, whatever the state is. So I think we're going backwards, not forwards. I understand there was a pandemic. Obviously, we had to do something because a lot of people were sick, couldn't come to work, or the aides themselves, but we can't allow the workforce to change so dramatically and go back to before the reform law where aides really did not have training.
Toby, thank you so much. Let me move on to Lisa Kaplowitz. I think you have a question next, and then Colleen, I've got you after that.
Well, I'm very concerned and interested in the discussion about infection control. Quite frankly, I'm not sure the teams have made a difference. I haven't seen a difference in terms of numbers of outbreaks in Virginia, for example. I think we need to take a much bigger approach and look at infection control. It's interesting that it's related to staffing, so everything's intertwined here. But infection control is not only controlling outbreaks, but we have problems with healthcare acquired infections. We have problems with infections acquired both in nursing homes, brought to nursing homes from hospitals. Anything we do is going to help big picture. It's basic safety, but it sounds like our approach to infection control needs to look at the bigger picture as well. And it sounds like a lot of that is linked to staffing. So I want to bring that up because I'm not impressed with what's happened with the teams. It's great that people are going in to look at infection control practices, but it's much, much bigger than that. We've talked about, single rooms. We've talked about staffing. Let's look at it in a big picture approach and not just look at it as a separate entity.
Yeah, so I'll just jump in to say, and I chatted this too, I think to Toby's point and your point just now, it could be, or could it be, a both and. So what we are hearing from people through Project Echo and other initiatives is that, DONs and directors of nursing and administrators are so stressed trying to find, somebody to work 3 to 11 who's a CNA or an LPN, and they cannot find anybody, and they are out of ideas on how to recruit. So there's just a lot that we're trying to do right now to solve the immediate concerns, because people are telling us, I have these immediate needs, I have to work on them before I can do the other things. But to Toby's point, there are definitely, and your point as well, the bigger picture here is what can we do longer term? So it's a bit of parallel initiatives here, the immediate, and also let's get started or continue the work that many of you are doing already on staffing models. That's why we talked about apprenticeships. We talked about career development. People have said they've trained everybody in their nursing home to be a CNA, so that when there's not a CNA for a particular group of residents, anybody in the nursing home can work as a CNA. We had somebody in Arizona on Tuesday who was an administrator who said that he got certified as a CNA and he works the floors, and that gives him tremendous credibility. So you can't just do it as if it's, a one-off, like you have to really do it, but things like that can make a difference.
Anyone also want to be responsive to Lisa? I also want, Lisa, in sort of response to your comment, to just acknowledge that on the committee, we think of COVID as a spotlight on a big stage.
Right.
And that we need to handle both, what this has illuminated for us, and also what the bigger context is. And infection control is a good example of that, as are many other things.
Well, I guess my immediate question for Dr. Ling, has this made a difference? I'm not convinced. Again, this is going to be a long-term issue, but I just am skeptical that what's been tried so far hasn't really made much difference.
So yeah, thank you for your question, Lisa. And I think we are making some progress. We have not solved this in totality yet. I think this is probably, it's a complex problem. And there are reports that the rates of outbreaks and COVID events or new cases is actually curbing, but not consistently everywhere yet. This is also related to some extent to you know, how hot the community is. I know we are very encouraged about vaccination, and, you know, just this was also pointed out in the last session, you know, vaccine data availability, right? And reporting so that you have that information. We are looking at the trends together with our colleagues from CDC and also ASPR very, very closely, because the question is not, you know, do you permit in-person visitation, but more, what do you need to consider in order to open up in-person visitation? And there are multiple factors here. And it's so complex, but I think we can get there through data, but to the points made earlier, and I appreciate Alice sending around all of the other parties who are involved here. This is not something that the federal efforts, CMS can solve alone, or even with just CDC, federal. It has to be all of us in this in order for us to really solve this and also address these other healthcare acquired infections that for some, probably the solution is similar, but others, it's quite different. And I'm still mindful of, you know, the social isolation and physical inactivity and all that are meaningful to our residents that we also have to solve too. So multiple goals, multiple parties, but we all have to pull in the same direction. It's going to take all of us to achieve what we know we can. So thank you.
I might mention, Dr. Ling, I think you just mentioned ASPR for the non-HHS geeks, the Assistant Secretary for Preparedness and Response, the Emergency Department.
So sorry.
Emergency Management Department. Okay, Colleen Galambos, I've got you next. Bill Scanlon on deck.
Great, thank you. Thank you, panelists, for your excellent comments. I want to go back to discussion that we started to have a little bit earlier. A number of you as panelists mentioned reforms are needed in reimbursement mechanisms. And specifically, you know, what is reimbursed? How is it reimbursed? And I'd like to hear from you. Are there any ideas on how we can better reimburse services, programs, and staff that promote quality of life? Sherry, you started to talk a little bit about that we need to be mindful of looking at quality of life and making sure that our attention is also on quality of life as it is on quality of care. But as you well know, that some of the roadblocks to really providing good services, good solid services in relation to quality of life have to do with reimbursement mechanisms.
So I can start, and I know others on this call have really thought about, you know, what the solutions and contributions are to really evolving towards a value-focused a payment construct, a different model of care that rewards are tied to outcomes that matter and are meaningful. So, you know, I think value-based and value-focused care is the opportunity. Keep in mind that we, you know, CMS did implement SNF VBP, but the way it was constructed and written, the implementation was based on a single measure, which is readmissions. And it was a requirement. The language that usually is in the law, you know, the statement and other measures as determined by the secretary was not there. So we actually were pretty stuck. And yet, we know that, once there are measures available and there is an opportunity that comes towards us, we would love to be able to insert other metrics that would speak to, the outcomes, even patient-reported outcomes, person-reported outcomes. We just need a data source. And fortunately, the data elements such as self-care, mobility, cognition, some of these are already, the data element alignment happened because of the Impact Act across post-acute care settings. And that those domains actually also align with something like the Promise tool that is available as a patient-reported outcome. So there's some alignment and work there. How do we capitalize on that? And is that the right signal that we'd have to test it out. But there's interest there. Would love to get there over time. So thank you.
Yeah. And I'll just add to everything that Dr. Ling just said. The practicality of what she was talking about is the measures have to be doable by the nursing home with the structure that we have. So we have to be careful that they're not so academic and so research focused that, no nursing home can actually, implement them. So we really need to think about what is practical, what could nursing homes do that would actually give us the answers that Dr. Ling is talking about.
I think if we limited, as the advocates are calling for, a direct care ratio requiring money to be spent on care so that money didn't get diverted to profits, management, self-dealing, we would have more money. And then I think we need to require things that we think are important. Social services is a very weak part of the reform law. It's a requirement only for facilities with 120 beds. So we know that some facilities have put more money into social services and activities. These are important things for residents' quality of life. Activities during the pandemic in particular, realizing that residents were not having families visit or friends, that they were really totally restricted to the nursing home. So a nursing home that put in an additional activities person. We could, I think what I would like to see the law say is, here's what we want you to do, and now we will pay you to do what we are asking you to do or telling you to do. And we need to have more in social services and activities for sure. But it's also a staffing issue. To go back to the question about turnover, there's turnover in nurse aides, partly because they're injured and sick, but partly because there's not enough of them. They can't do the job. And so people get very burned out and exhausted, and they get blamed. A typical case that I read about is a resident, according to the care plan, needs 2 individuals, 2 staff members for a transfer to move the resident from the bed to the wheelchair. One aide is in the room, tries to find somebody else who can help her, can't find anybody, so she tries to transfer the resident alone. They both go down on the floor, resident breaks her hip, the aide gets fired. We have turnover because people are not treated well. They're not paid appropriately, they don't have health benefits, they don't have career ladders, they are treated like unimportant people, as opposed to the people who know the residents more than anybody. But I think if we freed up money, we could spend it on things that are more important for quality of life and quality of care.
Thank you.
Thank you. Thank you, everybody. Bill Scanlon, I've got you next. Reggie on deck.
Okay, thank you very much, Kathy. And John, I have to say, it's very good to see you again. I've both appreciated and admired sort of all the work you've been doing over these last many years sort of on this issue. I always thought that this was an important, very important part of GAO's work. It wasn't just about whether dollars were being spent wisely. It was a question of trying to protect sort of vulnerable individuals from harm. And what my primary regret is we haven't made as much progress as we would have hoped for over all these years. But I was going to ask a question that is a slightly different theme, but Kathy's question to Alice started the discussion, and that was the question about special focus facilities. And my question is about resources, because we've been talking a lot about changing the oversight process and structure, but we haven't really talked about the whole issue of, do we have enough resources to do what we need to do once we decided what exactly the right thing to do is? And it goes to surveys, it goes to complaint investigations, it goes to ombudsman. And I'm thinking that this is the right panel to ask that question of, because you're the ones, I mean, for John, you and our IG's colleagues, that you're on the outside looking at the process. So you may have observations about it. Dr. Ling, sort of within CMS, I mean, if you can speak to freely, you may have a sense of it. And Toby, I know you've seen this sort of very much, and Alice probably too as well. So I think this is the right panel to be asking about, what do we need to think about in terms of the investment of resources in oversight? And we can talk about it as quality improvement and quality assurance.
Well, thank you, Bill, first. And I can just add a couple of things, but other panelists can chime in. And certainly you're right. I think I've heard a lot of discussion during the committee's panels about targeting more oversight of the poorest performers, and whether that means that there should be different oversight for performers. The Special Focus Facility Program is really the very limited way that is currently done in CMS's rules. And certainly the reason why it is so limited, that CMS will indicate, has been budget driven, and that they have reduced even during periods of budget cutbacks or sequestration, the number of facilities they could do that. So certainly it's, budgets are our priorities. And so if there is an interest in doing enhanced oversight of the poorest performing homes, I think your questions about whether or not that's where we're dedicating resources is important, since it is such a limited program to such a small number of poorly performing homes.
Yeah, and I would add to that if, there's budget office documents that are public documents that are posted on the CMS website, and it shows how much funding goes out to the states through the 1864 agreement, each year to cover their costs. And the funding's been flat for several years now, at least 2 years, maybe more. And so it's been a while since there's been any increase in terms of supporting the survey process. So, to your question, how would we think about resources? I personally think, having been, on the regulatory side at both the state and the federal level, I think we need to better support the regulatory and the survey processes so that we have smart people, experienced, skilled people with the knowledge to look at those processes and make them more efficient, make them more effective, make them more sustainable, and get them to look at the things that are really important to residents. And we're not there yet. So I don't know if somebody else wants to chime in.
I think we should limit survey agencies to doing enforcement, and not divert them to doing training and collaboration. There are other entities that do a lot of training for facilities. We have QIOs, there's ECHO, there are all kinds of training programs going on, but only the state survey agency, the regulatory agency, has authority to enforce the law. So I think they need to be focused on that job that only they have legal authority to perform. We know the QIOs get their money from the trust fund, so that money just keeps coming out. But surveys, as Alice said, the survey agencies have to be in the budget, and there's been a flat budget.
Just to add from the OIG, Kathy, a reminder, we have a report coming out in another month or two on this very issue and state performance on the SPSS. And then we spoke with state agencies at the beginning of the pandemic and to learn about their difficulties in going on site for these infection control surveys, and found a number of them. These were, in some cases, the same states who had been performing poorly on the SPSS for years, in some cases, states that had high performance measures. And they were dealing with the difficulties you would anticipate, like personal protective equipment and so forth. But they also just had these chronic surveyor shortages that seemed almost intractable. I mean, some of these directors were hanging by a thread, just sort of throwing up their hands not knowing where to go next to try to find qualified surveyors. So we knew that was a problem. We were surprised by the depth of the problem and that it was reported by states who seemingly, if you looked at the data, were doing well. So it's a nationwide problem with this shortage of qualified surveyors, as others have mentioned today, a deep problem that probably requires multi-level solution.
Ruth Ann, will you explain the SPSS, just what it is, instead of the acronym? You're on mute. You're getting a brilliant answer, but you're on mute. Okay.
And Dr. Ling would probably do a better job than I would, but the state performance survey system, is that it, the SPSS?
Standards, one or the other, yeah.
Standards.
System.
And
just doing an acronym check, so thank you.
Measures things such as timeliness of surveys, timeliness for specific types of surveys like complaints, which we've found particular problems with, and so forth. And we found there are some states who have persistent problems with this system, 4 or 5 states who have just been at the bottom forever, and then some states who are doing quite well by the performance measures, but in conversations with us, express some of the same problems that the poorly performing states had as well.
So Dr. Ling, I couldn't tell if you wanted to respond to Bill's question on resources. You had your
No, actually it was all said.
Okay.
Flatline budget, and the QIO budget also was narrowed as well. So I think, there's that piece of this. And I think a way forward actually is to ask ourselves, so what data do we have and what data do we need to put these pieces together, and then ask ourselves, so what is sufficient in getting to where we want to go, not just to put the pieces together and patch it together for now. But so anyway, just those added thoughts. Thank you.
Thank you.
Thank you all.
Thank you, Bill. Reggie Tucker-Seeley, you're next. Philip, I've got you on deck.
Great. Thank you, panelists, for a very informative session, and for our GAO and OIG colleagues first, and then for the other panelists. There's been a consistent theme in the discussion today that we need better tools for differentiating between bad actors and poor performers. So my question is, do these facilities primarily serve specific demographics of residents, that is racial and ethnic minorities, compared to better performers? And what tools do you use, or what is your approach for identifying and differentiating between these two types of facilities to ensure that these residents are consistently receiving good quality of care?
Just John, I can start, and certainly can give some observations on that, but also may want to follow up, just that I think some of our work has highlighted. I don't want to misspeak to some of the specific characteristics of both the nursing homes and the residents that often have shown up as being persistently poor performing. But certainly, and again, to go back to the very current environment with COVID, certainly seeing very real disparities in both the characteristics of the nursing homes and of the people that are being served in many dimensions. And so those are real concerns. I don't have the data at my fingertips to point to exactly what those characteristics are of some of our past studies, but I'm glad to follow up with the committee with where we have report on some of that do show sometimes small differences for characteristics like the ownership of the homes, whether it's for-profit or nonprofit, urban or rural, or the mix of residents that are Medicaid, Medicare, or otherwise.
Thank you. Anyone else?
Well, I think there have been GAO studies and others saying that for-profit facilities owned by private equity firms have poorer performance, and it's largely because they cut staffing. They have fewer nurses available and nurse aides to provide care, and so there are correlations. And I would just say, we know of facilities that have kept COVID out entirely, and an example is the Marilyn Baptist Home in Baltimore, which is the Black oldest Black-owned facility in the state. They have never had COVID, not a single case of COVID, and it's 90% Medicaid facility. So it can be done, but that's a not-for-profit facility. For-profits and private equity have worse records.
And if I could add, from John is talking about the work that we've been doing at GAO and sort of some of the characteristics that we've reported on before. We are also doing work right now trying to understand some of the characteristics, to link to Toby's point, that might be affecting the experiences of COVID in nursing homes. So that's work that we're currently pursuing.
Great,
You
thank
ready?
you.
Yeah.
Yes.
Okay.
So yes. So if we could get the copies of the reports that the first speaker mentioned, that would be fantastic. Thank you.
Philip, we've got you next.
Great. Thank you for for speaking with us today and for all that you do. My question is about the CNA role. There's general agreement that direct care workers should not have to leave the job to pull themselves out of poverty. Career ladders are a good idea, but I think it's also important for direct care to be a decent job in its own right, so that CNAs who love to give care and don't want to become nurses or supervisors can stay there. With that in mind, what is a realistic advocacy target related to providing a living wage for CNAs?
Well, I'll start, and I bet a lot of people on this call could jump in to also try to help answer the question. There have been a number of organizations that have addressed that concern and said, how can we, improve the job of being a CNA, working with residents, forgetting about all the career ladder pieces we talked about earlier. Some of the organizations that have looked at doing that have tried to set up a model and study the economics, the labor economics of doing that, and, with a small number of nursing homes. And so one of the ways to approach it could be, is there a single state that's maybe a small state that doesn't have an enormous number of nursing homes, but just, has a smaller number of nursing homes? Or is there a corporation or, a group of nursing homes under an umbrella that would be willing to do this and try it with a certain number of homes and, start with paying people a living wage, beyond the $12 or $13 an hour. Maybe it's, $20 an hour. I don't know, it would depend on the local market. But the labor economists who study this and publish on it are really focused on, okay, within that market, increase to a living wage, also benefits, also don't cut people's hours all of a sudden, because a lot of them are minority women, they're single parents, they're raising kids, their English is not their first language. This is in a lot of the country, the workforce we're talking about. And then if we did this over a year or two, could we study the benefits in terms of reduced turnover, increased retention, better job satisfaction, et cetera, as well as clinical outcomes for the residents. So there are a number of us, I'll put myself in that bucket, who really think the next step that we could do really soon would be that kind of a early initiative or pilot program, and then study the outcomes. Because things like a wage pass-through haven't really worked very well. The money doesn't get to the direct care workers. It goes elsewhere. So I don't know who else wants to chime in, but that's one next step that's possible.
Leading Age just wrote an excellent report, maybe December, saying that paying a living wage, it would be absolutely critical, and it would actually pay for itself because the improvements in care would be so significant. It would reduce turnover. It would create fewer problems, fewer care deficiencies. It would pay for itself if we paid a living wage. So the advocates and Leading Age and others have been talking. We've talked with Leading Age. We're going to have a broader meeting. How do we make this really happen? We think it's an excellent report and supported all the PHI recommendations that were discussed last month as well.
That's great. And Ruth Katz chatted in the link, so in the chat.
I've seen it. I just would like to see it actually become a reality.
Anybody else want to respond to Philip's questions on living wage? All right, keep us moving. David Stevenson, I want to check in with you. I think you had raised your hand earlier and lowered it. Jasmine has a question, but I want to make sure you got your question taken care of.
I have about 20 questions I could ask, but
and you've got 3 minutes.
Yeah, so I'm going to mention one just because of the panel's composition. So, David Grabowski and, Michael Wasserman and others had a blog today on transparency. One of the ideas that they mentioned, in kind of response to problems in nursing homes is an interagency task force that could respond rapidly, including OIG, GAO, CMS. And I'm curious, since we have those agencies, and I know you can't comment on this directly, but if there are ways that you do work together already or ways that you could work better together in the future, I'd love to hear it.
Sorry.
Go ahead, Dr. Ling.
Okay, I'll just mention just a couple of things, but it's really, in the context of, well, no, it's beyond the context of COVID. There are interagency work groups, and in COVID, we really had to turn the heat up and put that relationship and that interaction on the front burner to the point that, for instance, CMS, CDC, and the Assistant Secretary for Preparedness and Response, ASPR, on the phone, problem solving daily if needed, sometimes twice daily, depending on the availability of the data and prioritizing. I think we also have a really important opportunity to use that as a model of being fluid and being current, but have to back this up a little bit further. So, what are we learning about who's at greatest risk of poor outcomes, even within nursing homes across the state? And how do we still both address and fight COVID and resolve the pandemic, and take the opportunity to move in the direction of, more person-centered, goal-directed care? I think that conversation is happening separately through some of the national Alzheimer's work and the FACA committees. But herein lies the challenge. That conversation is happening over there. We're talking about COVID, and infection control and prevention here. It's all about the same people who are affected and who have to be part of the solution. So these are the type of engagement that is well worth the time and representation. And I will speak for CMS. We would commit to participating in something like that. In fact, I would volunteer. Over.
We in OIG would welcome that very much. And in other areas where we've done that kind of cross-agency collaboration, the Indian Health Service comes to mind, where we contributed for 2 or 3 years, very focused across the department, and had enormous gains. And so we certainly talk to each other all the time, but we would be interested, and we'll take that suggestion back.
And I just add that certainly I think the core of your question is also a theme that came from the CMS Administrators Commission, that report last fall on the need for that federal coordination and coordination with other partners. Certainly GAO's role as a congressional agency, we really appreciate the coordination with our sister inspector generals and oversight, as well as the communication that we have, professional communication with CMS, and the time they take with us and listen to that dialogue. So we're happy to engage at that level as well.
So I want to thank you, David, for asking your final question about collaboration, because this is very hard and very important. And I want to thank all of you who have participated in both panels today. Please stay connected with us as we continue about our work. I'm going to turn it back to Betty so that we can wrap things up for this session. So thank you all.
Thank you, Kathy, and to all of our speakers. We've heard all of your important messages today, and your words and your commitment will be really valuable as the committee moves forward to do this work. Also, as a reminder that anyone can submit feedback to us, including residents, families, and nursing home staff. We want to hear more about your experiences. And also, there will be a recording of today's webinar on the study webpage. So we thank everyone for participating in this very important work. I think we've heard many people say today, this is the time to improve the quality of care for residents and staff in nursing homes. And today will be an important step toward that goal. So thank you, everyone.